Good afternoon and welcome everyone. Welcome. Thank you so much for joining us for the Jamaica Midlife Health Society's third and final CME accredited Zoom webinar symposium. I want to thank you all for joining. Please make your way and we will begin shortly.
Hello everyone. As Sam from Ole just said, welcome to our third and final CME Zoom webinar symposium put on by the Jamaica Midlife Health Society. We have a great evening with us. We have an expert set of speakers, three of them. They're going to talk to us about the impact of menopause, andropause on your vision, your skin, and your oral health. What's new? I think that affects all of us. We also have a great amount of sponsors that's going to tell us about some new products and what's available for us. We also have Prof. Errol Morrison, who is going to open up for us. Now we're gonna I'm gonna send you over to my colleague Magdalena Cooper de News. I'm gonna thank you again for joining us this evening so we all can learn together. Welcome again.
Yes, welcome again. Thanks, Dr. Lisa. It's another great opportunity for us to work together as hosts today. I'm looking forward to that. Let us pray. Father in heaven, thank you so much for this opportunity you've given us to have this third JMHS webinar today as we discuss the issues that affect us in midlife and beyond. Help that whatever is shared by our experts and presenters, that each one of us will have a takeaway, not only for ourselves, but to share with others so that we can help someone along the way. Thank you for hearing us. Thank you for loving us. For Christ's sake, amen.
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 Over to you, Dr. William.
Oh, okay, straight to me. Okay, thank you very much, moderators, and thank you for our attendees here this evening. Here we have about 245 already, the last count. I'm going to start with a little joke. So there was this psychiatric patient in Bellevue, and he went to the doctor, and the doctor wasn't sleeping because anytime he slept, he saw rats playing basketball. The doctor was so puzzled, and he said, all right, it has been happening for 2 weeks. You're not sleeping, so I'm going to give you a sleeping tablet tonight. He said, no, not tonight. The doctor asked him, why? He said, no, it can't be tonight because tonight is the finals. And that's why he didn't need a sleeping tablet tonight. Tonight, or this afternoon, it's our final for the year, but we are dealing with something new that we haven't seen before. The World Menopause Day usually falls on the 18th of October each year. And this year they're looking at the impact on menopause on cardiovascular diseases in menopausal women. We have decided to change it a little bit and focus on other areas we have been dealt with over the years. Now, the JMHS brings to you the very important seminar this afternoon. Thanks to the tireless efforts of our executive team members, we believe in teamwork makes possible the dream work. You may be aware, or all of us may be aware of the menopause, which is when estrogen falls rapidly in women with a number of symptoms and signs. But now there's a new concept of andropause, where andropause testosterone levels also decline, but gradually, and therefore the signs and symptoms are not so evident in aging men. And the JMHS actually started as the Jamaica Menopause Society, focused primarily on women. And we didn't see many men for the last 25 years attending these forums because they were not interested in those topics. So as JMHS rekindles efforts, it focused primarily on women, but then the interest of men started to be felt when we started discussing other issues like heart diseases, bone diseases, mental diseases, all right? So it's now reaching men too. as we discuss all these topics throughout the year. We also deal with topics like estate planning and generational wealth. We have dealt with the usual signs and symptoms of menopause over the years, and today we're looking at the eyes, that's our vision, oral health, and the skin, which is usually not emphasized on, but they also have problems during aging. Now, the advancement of scientific research and knowledge, we are living longer. And so these health challenges are more evident, and we are all going to have to go through them as we live longer. So on behalf of the JMHS, I wish to bring you greetings, and I welcome you all to another magical moment in our history. Welcome and thank you.
Thank you, Dr. Brown, our president who brought those greetings. Now it's time to get greetings from the one and only Marigold Harding, who is our JMHS sponsor. And it's so good to see her online, looking as great as ever, as usual.
You mean
so
patron.
Our patron, yes, our patron. Sorry, our patron. Over to you now, Mrs. Harding.
Thank you very much. And I'm going to continue with a quote from E.C. Mackenzie, author of 14,000 Quips and Quotes for Writers and Speakers. And he says, middle age is when your memory is shorter, your experience longer, your stamina lower, and your forehead higher. And he went on to say about the women, a middle-aged woman is one, too young for Medicare and too old for men to care. And he says for the men, middle age is when a man's favorite spot is in front of a TV set. Master of Ceremonies, President Brown, members of the executive, Professor Errol Morrison, distinguished presenters, good afternoon. Ladies and gentlemen, it is my pleasure to bring you greetings today as the patron of the Jamaica Midlife Health Society. In April 2007, 26 years ago, the Jamaica Midlife Health Society, operating under the auspices of Medical Association of Jamaica, emerged out of the Jamaica Menopause Society, as Dr. Brown said earlier, which was founded in November 1997 by past President Drs. Venice Bernard Wright and Dr. Faye Whitburn Morrison. Since its inception in 1997, the Jamaica Midlife Health Society has never lost focus on its objective to promote optimal health for adults at middle age 45 to 60 and beyond through education. Prior to COVID-19, the JMHS hosted several face-to-face webinars addressing all aspects of health issues. They visited and made presentations at health fairs and expositions. Currently, JMHS hosts 3 online webinars annually, focusing on health issues that faces women and men at the menopause and andropause stages of their lives, educating the public, the medical fraternity at the webinar, through specialists who excel in addressing those health issues and provide the relative guidelines in handling them. The team continues to participate and make presentations on vital topics at health and wellness fairs. JMHS messages have been reaching more people in recent years, and persons seek better health solutions to their health problems through ongoing prevention measures. Early diagnosis, various effective treatment modalities, and adequate rehabilitation. The membership has and is increasing due to the impact and fulfillment of JMHS mandate. These accomplishments could not be achieved Without the support of JMHS's committed sponsors, many of whom have sponsored JMHS's webinar consistently over the years, and JMHS's hardworking, exemplary executive board members, volunteers, led by their dynamic president, Dr. William Brown, who expend their time seeking solutions and innovative ideas that will benefit the membership. JMHS, one of its dedicated members in the latter part of 2022, Mr. David Pennico Jones, passed. Today, we pay tribute to his years of service to the organization and extend our support to his wife. Those among us who have recently lost a loved one, we extend our sincere prayers and condolences. Members, continue to seek after good health and ensure that you educate, participate, and take effective measures in dealing with your health and well-being. Avail yourselves of the free webinars that are available through the JMHS and ensure that you maintain contact, build friendship, and offer encouragement, as it is at this time of our lives we need each other. Most importantly, unity is strength. Have a wonderful afternoon, and please enjoy the rest of the program. Thank you, my good friends.
And thank you for that wonderful introduction and the joke. I didn't hear many people laughing, I suppose because their mics were muted, but I'm sure everybody had a good laugh to start off with. Thank you very much indeed. And of course, the points that you made, we really appreciate. Okay, next on the agenda is Professor Morrison. Am I correct? No, it is overview of Professor Morrison. Yes, next, you're next.
Hi, Magdalena. I know you would have forgotten me. So much time has elapsed since we last spoke or greeted each other. But hello,
Forgive
everyone.
me.
Hello, everyone.
And
Dr.
I thought you would have said to me, ladies before gentlemen.
Okay. All right. Dr. Lisa, so good to see you and to hear you. And I trust that much of the information which might, be discussed here, we may be hearing it further on doctor's orders.
Let's see.
Dr. William, as usual, I miss those jokes of yours. And if time does allow and health does allow, I must, reconnect to benefit from that sense of humor that's so well known. And Patron Marigold, good to hear you. And I trust my good friend and colleague Ozzy is listening in. My greatest regards to him. Friends and colleagues, all, it's good to be with you this evening. And as I heard the history, I thought I too would put my 2 cents in, because directly and indirectly, I've been associated with the Midlife Health Society from its inception. That is when it was then called the Jamaica Menopause Society. And indeed, I still have handouts in my office, handout pamphlets, left there by one of the co-founders, Dr. Faye Whitburn, otherwise known as Mrs. Faye Morrison. Indeed, I used to hear the calls for information, and the men began clamoring for their inclusion, and I saw them coming more and more to some of the meetings. And hence, the organizers soon added Andropause in brackets to give the men some degree of comfort. Then came the critique of the name menopause. Left, right, and center, they were saying, why menopause? We want it to be more all-inclusive. and the organizers yielded and renamed it the JMHS, which we currently enjoy, namely the Jamaica Midlife Health Society. To my mind, this organization simply focuses on an aspect of aging that looks at the consequences of reducing levels of the sex hormones. This affects every cell in the body. And this afternoon, I note you are looking at a few of these groups of cells, namely the skin, the eyes, and the mouth. I raise for your consideration the fact that this is nothing more than a non-communicable condition which is worthy of being included under the benefits of the National Health Foundation Fund, rather. And I tell you why. I have, and I continue to hear the complaints of individuals being treated by one or more of the drugs commonly being exhibited in this condition. Costs. And even when they are available, as quite often they may not be available in the country, you know, that too has no cushion unless there is some kind of health insurance to offset it. Note, you would have seen even in today's newspaper, the fact that the NHF has added 5 new beneficiaries. Cancers of the gut, the blood, and the lung, Parkinson's and thyroid diseases, all age-related. Why not the medications prescribed for the conditions of reduced sex hormones? That is, your anxiety, the depression, the sweating, the flashes, the hair loss, the thinning of the bones, the memory loss, and yet more. I thought I would just leave that with you for further thought, and hopefully out of those discussions may come some action, because I see scouts from the NHF looking around for more and more conditions to support once they come under this umbrella of the chronic non-communicable diseases, which, as we know, is responsible for over 70 to 80% of deaths nationally and internationally. I do wish then for your continued growth in your reach and in the participation in the healthcare landscape of our country. And somehow, and I may be wrong here, but somehow I think we ought to be reaching even more importantly to the wider Caribbean. Those territories, I think, are certainly in need of this kind of consideration and deliberation, which helps so many of us who reach this age group. This afternoon in particular, then, I'm happy to be sharing with you all once again. And indeed, I feel privileged to be asked to declare this symposium open. Bestest, as I would say, and blessings to you all. I look forward to an interesting and communicative afternoon. Thank you.
Thank you so much for opening the session. Really, this webinar. Really thank you for your comments. The next 3 items on the agenda will continue unannounced.
Good day, I am Sheldon Cuff, Alcon's representative from CARMED, and today I'll be talking about how to achieve clear vision by managing common eye diseases with Alcon's effective solutions. Now, the two eye conditions that I'll be looking at are dry eye disease and age-related macular degenerative disease. What is dry eye disease? It's the inability of tears to properly lubricate the eyes. It's caused either by a decrease in the production of tear or increase in tear evaporation. It affects almost 1.4 billion persons worldwide. If untreated, dry eyes can cause permanent damage to the eye surface, leading to a loss of vision. Now, the diagram below shows a dry eye versus a healthy eye. And as you can see, in the healthy eye, the conjunctiva is clear, whilst in the dry eye, it is dry and irritated, indicated by the redness. Some common dry eye symptoms are stinging or burning of the eye, sandy or gritty sensation in the eye, redness of the eye, and even episodes of blurred vision. Also, excessive tearing. Now, this is where the eye is runny and watery. Reasons for dry eyes. Age. As we get older, there's decreased production of tears. Gender. Women have a high incidence of dry eyes due to hormonal changes, such as in pregnancy and menopause, health conditions such as diabetes, lupus, rheumatoid arthritis, among others, and medications such as antihypertensive, sedatives, and antihistamines. The environment in which you are, such as a windy environment, a smoky environment, a dry and humid environment. Use of screens all day, such as a computer or television, can lead to increased incidence of dry eyes. The two main classifications of dry eyes are aqueous deficiency dry eyes and evaporative dry eyes. Now, the symptoms seen in aqueous deficiency dry eyes are the stingy or burning eyes, sensation of gravel or gritty eyes, and sometimes the eyes is even red. In evaporative dry eyes, you have excessive tearing of the eyes and the eyes are runny and watery. Now, the solution for dry eyes. Cysteine, the #1 recommended brand. It is specially formulated to moisten the eyes. Shake well before use. Instill 1 or 2 drops in the eyes, and this will deal with all the common symptoms of dry eyes. Different types of cysteine available in Jamaica are cysteine original, cysteine ultra, cysteine gel drop, and cysteine balance. Now, cysteine original, cysteine ultra, and cysteine gel drops, those are the first three. The green box ones, they are indicated for aqueous deficiency dry eyes. And as I mentioned, aqueous deficiency dry eyes, the symptoms are redness of the eye, itchy or gravelly feeling in the eye, burning or irritation. And cysteine balance is indicated for evaporated dry eye. And the symptoms of that is a runny, watery eyes, excessive tearing. The second condition we'll look at is age-related macular degenerative disease, AMD. Now, AMD is a degenerative eye disease that reduces color perception, contrast, impairs your ability to read, drive, and even recognize faces. Now, it can cause permanent or irreversible damage to your central vision, that is the images directly in front of you. And macular degeneration can progress slowly or strike quickly in a matter of months or even weeks, causing severe loss of vision. 3 symptoms of macular degeneration. A black spot appears in your vision that doesn't disappear. Images are distorted. You have double vision. Now, delay these symptoms. Don't let this happen to you. We have the solution, and it is called Vitalux Plus. What is Vitalux Plus? It's a complex multivitamin and mineral supplement, especially formulated to maintain healthy vision. The antioxidant properties defend against the degenerative tissue process and aim to reduce the likelihood of developing AMD. Vitalux Plus is a time-release eye multivitamin, especially indicated for adults 50 and over. It contains lutein, zeaxanthin, vitamin C and E, zinc and copper, vitamin B2, selenium, and the dose is 1 tablet per day with a meal. Now, the lutein and the zeaxanthin are not found in your regular multivitamin. These are specially formulated for the eyes. right? And what they do, they'll absorb ultraviolet. That's a bad light that will damage the retina of your eyes, so preventing you from focusing on objects. Now, reduce the oxidative damages to your eyes with these antioxidants. Defend against the likelihood of developing AMD and protect your eyes with Vitalux Plus. It is the healthy way. I thank you.
Hello everyone, this is Health 2000 Canada, otherwise known as H2K. Here's a reminder of the products we offer that can be beneficial for your eyes and skin.
Timolol 0.5% eye drops treats glaucoma and high pressure in the eye, reduces damage to the optic nerve that can lead to vision loss or blindness. Adults and children 2 years of age and older use 1 drop in the affected eye 2 times a day or as prescribed. Timolol. Be it an itch or eczema, get quick relief with Baytad. Baytad is an anti-allergic topical corticosteroid cream that treats eczema, contact dermatitis, allergies, and rashes. Baytad's main ingredient is betamethasone dipropionate, which reduces the swelling, itching, and redness that can occur in these types of conditions. Baytad. Esquiderm Cream. A triple combination ointment that works together to treat various skin conditions. Betamethasone, the anti-inflammatory, clotrimazole, antifungal, and gentamicin, the anti-infective, work together to heal the skin. Esquiderm treats primary irritant dermatitis, seborrheic dermatitis, eczema, allergy contact dermatitis, and psoriasis. Use Esquiderm by applying a small amount of cream to cover the affected area of skin with a thin, even film and rub it in gently. H2K Topicals brings you Esquiderm Cream, a brand you can trust. Stop that itch with clotrimazole cream, a broad-spectrum antimycotic with fungicidal action cream. Clotrimazole 1% cream is a trusted topical antifungal that readily penetrates the stratum corneum, rapidly relieves itching and burning, and achieves high and sustained concentrations. It provides high cure rates for the following conditions. Clotrimazole cream. Hit fungi hard with ketoconazole 2% cream. Ketoconazole is a broad-spectrum topical antifungal, effective against dermaphytes and yeasts, such as the below. Treatment is to apply once or twice daily to infected areas. Ketoconazole 2% cream. Or Total Neem Cream, a fast-healing herbal skin cream made with natural ingredients such as neem, aloe vera, sesame seed oil, zinc, asoka, and licorice, that helps to reduce topical pain, calms minor skin inflammation, treats minor skin infection, and promotes healing. Boratotal's powerful natural ingredients work together to heal skin issues fast and prevent further infection from bug bites, cuts, scratches, and burns, dry, cracked skin, sunburns, and is sensitive, skin-friendly. Try Boratotal. Silvercant, fast, effective healing. Silvercant provides fast relief of second and third degree burns, prevents infections from burnt surfaces, wounds, and chronic ulcers. Try Silvercant for all your wounds and burns. Get fast pain relief with Go-Gel for arthritis, neck pain, back pain. Go-Gel's non-greasy, safe formula delivers medication on site. No prescription needed, so keep going and go beyond your limits. Go-Gel. Pain relief is just a gentle rub away. Formulated for faster pain relief, diclofenac 1% gel is an anti-inflammatory that is used for pain management, such as tendonitis, bursitis, osteoarthritis, periarthritis, fibrositis, tenosynovitis, sports injury, sprains, and strains. Gently rub a small amount of gel onto the skin around the painful and swollen areas 3 to 4 times daily for fast pain relief. Diclofenac gel. Naturella 5-in-1 cream. Natural ingredients, tones skin, reduces wrinkles, improves skin texture, moisturizes, has sun protection. Naturella. Be flawless.
This is Amoy Rickman saying thanks for listening. All our products are available in pharmacies island-wide. Please ask for it. Doctors, please write H2K before the drug name on your prescriptions. Have a wonderful
Over to you, Magdalena.
Yes, thank you. I was there sitting down, enjoying the ads. Really good. I hope everybody has at least one item in their cupboard and going to get the second one soon. I have some of them. I hope you all have some of them in your cupboards as well, especially since we are midlife and beyond. Okay, so the next presentation, and I'm going to do a screen share here. I'm going to do a presentation to introduce the next speaker. And let me just fix my, is everybody seeing my screen?
Yes.
Yes, Magdalena.
Everybody see my screen? Yes, okay. Okay, thank you. I'm trying to see how I could get up to it, but it's not going to work, so it doesn't look as though I wanted to get into
Go into slideshow, Mag.
Yes, I'm just trying to move it into slideshow, but it's not allowing me to do that right now. So, so what I'll do is I'll just go into what it is that I'm doing. All right, so everybody can hear me and that's fine. So our next presenter is Dr. Angela Mattis Johnson. She's an ophthalmologist, consultant ophthalmologist, AB Vision Eye Care. And I actually went online to look for AB Vision Eye Care, and I've actually got the link on here. So everybody can go and put in AB Vision Eye Care to get in touch with Dr. Angela Mattis. And her telephone numbers, I've put it here, 920 of the office, 3600, the Kingston office, and 903-876 before them, 3238 for the Linstead office. Former head of ophthalmology, KPH, lecturer, member of the American Academy of Ophthalmology, Ophthalmological Society of Jamaica and West Indies. Hobbies. I thought it was a very interesting hobbies for Dr. Mattis Johnson. She likes dancing and running, the 5K. Probably she can see very well. So her presentation topic is preventing and managing your deteriorating vision at midlife and beyond. Over to you, Dr. Mattis Johnson. What's happening here now? Yeah.
Thank you very much for that introduction. I would certainly like to thank the Jamaica Midlife Health Society, the executive, for inviting me to speak this afternoon. And yes, it has been a long day so far. I started at 6 a.m. this morning with the Pink Run 5K. So I did that at 6:30. And yes, it is a good way to get your morning started. Now, some of my presentation, in that previous presentation was half of my presentation actually. So it has made it a little bit easier for me. I am going to now share my screen and tell you exactly what I am talking about. Okay, so we're gonna go from beginning. Okay, actually I don't see it. It will come up over it. Not over it. I'd just like to get something. Just a second here. Let me close my thing. Okay. Just a second. Yes. And then
while we're waiting for Dr. Mattis to come up, please note everybody that when this presentation is completed, you'll be given the opportunity to ask questions. So please take a note of your questions that you'd like to ask.
You can also type the questions live in the Q&A. So just so that you don't forget the question that you have, please type it in the Q&A. Doc, is it that you're trying to see your notes?
when it comes up, it doesn't, the thing doesn't come. Oh, okay.
You were good just now.
Mattis.
You were good just now. So go back to what you were doing before this came up and you were fine. Yes, you're fine.
Yes, now I just a quick word. As I am a lecturer and I lecture medical students and I lecture optometry students. And when I was asked to do this presentation, I was trying to figure out how to present it without giving you an ophthalmology lecture. So when Mr. Lo asked me to submit the MCQs, I hadn't yet done the presentation and I was, so, you know, you might find the questions seeming like, oh my God, this is an ophthalmology lecture. But I wanted it to be not a lecture because you might lose sight of the essence of it. If I go into too much detail on, you know, symptoms and treatment and so on. So I try to, it's going to be mentioned, but I try to get away from it. So the presenter earlier who presented those products that we use in ophthalmology did a wonderful job, because I'm going to mention dry eyes and I'm going to mention age-related macular degeneration. But they certainly went into a little bit more detail than I, you know, I'm going into for this presentation. So without further ado, I think I'll just, hopefully it will not be too didactic, because I really don't want it to be too didactic. So, let's see if my thing will start. Oh, why is it not moving? Okay, let's see. Okay, here we go. Here we go. So so in terms of, I know this is the Midlife Health Society and it's about the hormones and so on, but in aging, in the eyes, it's more aging rather than menopause, although, or andropause, if you will, because menopause and andropause, it's aging. So it's more or less the same thing. And so when we look at the vision as we get older, we want to differentiate between what we consider to be reduced visual function in the normal healthy person, as opposed to the older person with specific age-related disease. The two are linked, but they are not the same. The reduced visual function is physiologically what is expected, whereas as we age, we are more susceptible to disease, and disease comes with eye problems as well. So there's a slight little nuance when we talk about that. So I want to look at, you know, when I do this presentation, mainly look at, because, you know, the presentation is how we can manage and, you know, preserve our eyesight as we age. We want to look at and emphasize our prevention or early intervention, which certainly will mitigate against severity of disease. So now, as we get older, what is normal and what is not normal? I'm going to look at some normal conditions, and certainly the list is endless. And I did not want to do every single thing. I just wanted to give a good overview of the issues. So there are some physiological changes where we can do nothing about it. These things happen, and certainly as it relates to change in hormones, they're going to happen. And then there are pathological changes too. As we get older, these things are likely to happen under certain conditions. So let's look at what's normal. First, we're going to look, we can't get away from a little bit of anatomy. And so I will look at just a refresher's course on the eye and how the eye works. So we're going to start with a beam of light. I'll just use my pointer here. And that beam of light is bouncing off an object and is directed toward our eyes. The light is bent, starting with certainly our tear film, as was mentioned before, the tears, and our cornea. And it's focused through the cornea and our lens. This is our intraocular lens, our crystalline lens. And once the light passes through the lens, it is then received by the retina, specifically the macula. And the retina is our light-sensitive layer. And the macula is that concentrated area where we have all our rods and cones. And it is the holy grail of the eye. That macula is very important. As you heard earlier, so as I said, you know, it will make my talk a little bit easier because you heard about macular degeneration. And so the retina transmits energy in the form of light as an electrical impulse, and that is transported to the brain via our optic nerve. And once this information is sent to the brain interprets it and it allows us to see. So that is our quick synopsis of the eye. So we see, but what is visual acuity? Visual acuity is a measure of how clearly we can see. And we use a Snellen chart. And so that system that I showed you before, where that beam of light from the object goes straight from the retina to our brain, when that system is working perfectly, a person is said to have 20/20 or 6/6 vision. Now, 20/20 means 20 feet. 6/6 is metric and it means meters. So we tend to more use 6/6 because we are metric. The United States, not metric, so you will still hear about 20/20. We still talk about 20/20 and you hear about 20/20 vision. So we can't get away from that because the US still talks about 20/20. So you have a Snellen chart and you're at a distance of 6 meters or 20 feet. And that lettering on the chart that you are supposed to be able to see at 6 meters away, when you see it, you have 6/6 vision. Now, if you have, say, 6/12 vision, what does that mean? It means that you can see at 6 meters what a person who has normal vision can see all of 12 meters away. So the person who has to come closer, who can see, so at 6, has to stay at 6 meters to see that object. And so decreased vision, it means that when you see the bottom number gets bigger and you have the bottom number bigger, it means your vision is worse than what the normal person can see. So we don't use, terms as blindness and so on, because those words have significance. For example, the WHO definition of blindness is defined as a visual acuity of less than 3/60. Now, 3, that top number means the person is moved closer to the chart at 3 meters. And so they are closer at 3 meters, and at 3 meters, they can see what the person who has normal vision can see all of 60 meters away. And that 3/60 vision is in their better eye with the best correction that they can get. So that is the definition of blindness. In ophthalmology, we use blindness differently because we tend to look at blindness as no perception of light, meaning you can't see anything at all. So from the ophthalmologist's point of view, but for medical legal purposes and so on, they will talk about somebody who is legally blind, and there's a definition for that. So we see decreased vision in conditions as refractive errors, cataract, macular degeneration, and we can go on. So here we're going to look at presbyopia. Now here we talk about something, as I showed you in my slide earlier, this is one of the quote unquote normal changes that occurs. And presbyopia is a gradual loss of the ability of the eye to focus on objects closely. And so, because this is our midlife group, we all can identify with this annoying part of getting older, where we have to hold things all the way in front of us, because when we hold it closer, we are not able to focus on it. Because what happens here is that the lens of the eye, remember that lens that I showed you earlier that helps in focusing the object, it usually is very flexible before the age of 40. At or around the age of 40, that lens loses the flexibility. So it's no longer flexible. You know, like you have a zoom lens of a camera, it zooms in when you're looking at something close and it zooms out. Well, that function of the lens, we lose it as we get older. And so when it's working well, that flexibility allows us to see objects that are closer. So post age 40, once it becomes less flexible, it becomes more difficult, and we start to hold things at a distance away. And so here is where we have to introduce reading glasses, which improves our ability to see. We have to get a lens which can compensate for that loss of flexibility from our own lens. Contrast sensitivity. Now, contrast sensitivity, it refers to the ability or lack thereof to distinguish between objects against its background. And as we get older, contrast sensitivity declines. So if you will, it's kind of the other part of our Snellen chart, if you will. Snellen chart can be considered the quantity of vision, whereas contrast sensitivity looks at the quality of vision. You can have good Snellen chart 6/6 vision, and your contrast sensitivity is very poor. So what that means is the ability to see objects that may not be outlined clearly or stand out in their background. So you're looking at stairs is a very good example of this, where the edge of objects, you're not able to distinguish it very clearly, and so you can miss your step and so on. So that is where shades of gray, or the ability, you know, sometimes you will see also persons who do presentations, and the colors they choose and the background that they use, you're like, I'm not seeing this very well. So one has to be very careful when you write on white background and so on, that the color you choose will give you a good contrast. Of course, black and white is ideal. So most things use black and white. But when you start using yellows on white, it becomes difficult. And so one has to be careful with that. So that is our contrast sensitivity. Then we look at glare. So again, as we get older, the changes in light sensitivity is normal. You're going to get a change in that. And so it's a continuum, and it starts, as a matter of fact, it starts even with that lens that loses flexibility. So that's where it starts. That's why it's a continuum, and it's not just suddenly occurs overnight. So by the time you reach in the 60s, your pupil size gets smaller. And so when it gets smaller, it's harder to see when the lighting is dim, and you become more sensitive to glare. So here it is, you can see this situation where night driving sometimes become more difficult, and it's all a part of this change that we see. And what happens too nowadays is that we have LED lights, and LED lights are great, but they are also many lumens brighter than our old sodium light. And so night driving can be certainly more difficult. You have bright LED lights, and it's not that you're going blind, it's really that the LED lights are very bright. Most of the vehicles are SUV vehicles, and so they are higher, and so the light comes down at you, and it certainly makes it more difficult, especially with that contrast sensitivity, where night, when it gets dark, it gets a little harder to see. So yes, it does create a slight challenge. And so one of the things one can do is to avoid looking directly onto the headlights of oncoming vehicles at night. Now we're going to look at flashes and floaters. Now, flashes and floaters, they tend to occur as we get older. And again, I want to stress, these changes are not necessarily related to hormonal differences. It's more related to our aging differences. And as I said, aging and hormones tend to go hand in hand. So what happens is we have our vitreous gel. The vitreous is in the back of our eye, the posterior segment here. And the vitreous gel tends to, it's usually a very thick gel-like substance in the back of our eye. And as we get older, it starts to degenerate. When it degenerates, it starts to shrink a bit. And when it shrinks, it starts to form little pockets of cells. And once that shrinkage occurs, it starts to separate from our retina. Remember, our retina is our light-sensitive part of our eye. And when that vitreous starts to separate, it can pull on the retina. Now, when it pulls on the retina, it can tear the retina, it can pull on a blood vessel and cause bleeding, or it just disturbs the retina and it gives a flash of light. The retina does not feel pain. Whenever the retina is disturbed, you get a flash of light. So if you used to read comic books and so on, where you got a punch in the eye or so and you see stars, that is where those stars are coming from. Any disturbance of the retina gives off a flash of light. So when that gel starts to shrink, it can pull on the retina. Now, when it pulls on the retina, it does not necessarily damage the retina. It does not necessarily tear the retina, and it does not necessarily cause bleeding, but it disturbs it. And when it disturbs it, you get a flash. So flashes and floaters go hand in hand. And so you see this flash, which can be very disconcerting. And you see these floaters that look like little squiggly things, you know, around. And so they can be annoying. However, what should you do when you experience these flashes and floaters? Usually, you should, as a matter of fact, I say it is important that your retina be examined to make sure that there are no retinal problems needing treatment, such as retinal tear. You see, I say here, beware of a retinal tear or detachment, because if you don't get your retina checked, you will not know if that flash was just a little disturbance or it actually pulled a piece of the retina along with it, which can lead to a detached retina, which is a sight-threatening condition, because a detached retina can lead to blindness if it is not dealt with urgently. So here we have normal vision here, and you see the little squiggly lines. And so we are not worried about the little squigglies that you see. They are annoying, and they are really a reflection. You see that black color, it's reflected off your retina, and you see these black things floating around. Usually when they just occur, they seem very large, but once the brain gets used to them, they sometimes shrink, or sometimes you don't even see them anymore. You have to look for them. They don't disappear. We don't give eye drops to treat it. We leave it alone because we are more concerned with ensuring that your retina has not been damaged. dry eyes was dealt with perfectly previously, and I thank the presenter because they went into a lot more detail than I would want to go in when it comes to dry eyes. And yes, dry eyes really, I would say, used to be, postmenopausal, because when estrogen levels fall, your tear gland produces less tears. And so we get dry eyes. But nowadays, we have lots of other conditions that can cause or predispose you to get dry eyes. Because everybody is now looking at a phone or computer screen for long periods, or environmental conditions, as was mentioned before, driving for long periods, you blink less often. And so when you blink less often, your tear film evaporates and your eyes dry. And so, yes, you can have tear film abnormalities because, as was mentioned before, you have evaporative, you have the oily layer of the tear film, which is the outer layer, which protects it and prevents it tears from evaporating. And so you can have abnormalities there. But generally speaking, aging is a condition which can predispose you, which will predispose you to get dry eyes. And of course, certain medical conditions, especially our autoimmune conditions, Sjogren's disease, SLE, arthritis, and the list goes on. And so the preparations, which obviously was promoted earlier, can be used to treat this condition. So those were just a few of the normal changes that may be annoying, but we can manage them, but we expect them to occur. These that I'm going to talk about now are some of the not so normal changes that we see as we get older. Now I'll mention, and these are the conditions that I'm going to mention. And in Jamaica, the main causes of vision loss in this order are refractive errors, cataracts, glaucoma, diabetic retinopathy, and macular degeneration. Of course, there are many, 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 many more conditions. The list is endless, but I want to touch on these because it can give a good example of lots of other things, certainly, but these are the common causes of vision loss in Jamaica. So refractive error. So we all know we all wear glasses for the most part, and we know that a refractive error is a common eye condition, and that occurs when the eye's shape prevents light from focusing directly on the retina, because everything must go on the retina for us to see clearly, and our vision is blurred. And there are really four main types. We have astigmatism, we have hyperopia, which is farsightedness, we have myopia, which is nearsightedness, and we have presbyopia. Presbyopia is a specific type of refractive error, which is what I mentioned earlier, where our lens starts to lose the ability to accommodate and focus. And so astigmatism, hyperopia, and myopia, these are corrected with glasses, and you have to get your eyes examined to get your correct prescription so that you will see and focus clearly. Now we're going to look at a cataract. And a cataract is really a clouding of the lens of the eye. And I show you these pictures here because there are many different types of cataracts. Of course, I'm not going to go into a lecture on cataracts, but there are different types of cataracts, and different types of cataracts can cause visual impairment differently. So, for example, we can have nuclear sclerosis where the lens protein changes and refractive index changes, and you end up getting what we call the second sight. So persons will say, oh, my grandmother can see clearly and she doesn't need her glasses. I will tell you, yes, it's as if it's presbyopia in reverse. You start to see near objects better because the refractive index in your lens causes you to see near objects better, and you can't see far objects. So it's like a flip side of what presbyopia is. But that too goes, and you start, and of course, you will lose that nearsightedness. So your grandmother will say, oh, come close, let me see who it is. That is, and so when patients come and tell me that their grandmother has great vision because she can string a needle, she's having a nuclear sclerotic cataract, okay? So there are different types. You have cataracts where the cortical layers get clumps, and so it changes your vision. But the end point of a cataract, it interferes with your vision. And that is when something needs to be done. Just saying you have a cataract does not mean that you need surgery. When your cataract starts to affect your vision, that is when you need to do something about it. And so it is common in older adults. It's kind of a crossover because it is kind of expected and it is kind of pathological because your lens protein changes right there from we start with presbyopia, that lens is changing. But when it goes into that spectrum now where it starts to get pathological, that's when you need to do surgery. So here we see somebody with normal vision, somebody with a cataract, and certainly depending on the type of cataract that you have, it can also change the hue. And so the colors you see may look a little bit different. And so patients who do cataract surgery will say, oh, I didn't know that my room was colored blue because, you know, I was seeing it and it was looking a different color. But you kind of get a blurred vision, and that's what happens with a cataract. And so aging is the most common cause. Then the other causes include diabetes, trauma, corticosteroid therapy. And corticosteroid therapy includes systemic corticosteroids. It includes topical corticosteroids. It includes topical corticosteroids, meaning eye drops, and also topical corticosteroids on your skin. So the presenter who presented earlier and spoke about the corticosteroids, one has to be very careful. And so the dermatologist has to be very careful because remember, it can predispose you to develop cataracts by prolonged corticosteroid use. And so what do? You want to keep your spectacle prescription updated, and certainly surgery is warranted at the appropriate time when it starts to affect your ability to function on a daily basis. Now, glaucoma. Glaucoma is a group of eye diseases. It's a group. It's not one thing. It's a group of eye diseases that can cause vision loss and blindness by damaging the optic nerve. And associated with that glaucoma is the intraocular pressure. The intraocular pressure alone is not glaucoma, but glaucoma is associated with that intraocular pressure. We call glaucoma the thief of sight because it doesn't come with the bells and whistles for the most part, pain and redness and so on. There are certain types of glaucoma that may present that way, but chronic open angle glaucoma is the most common type. And so elevated intraocular pressure is one of the most common signs of open angle glaucoma. And so you also get visual field loss and optic nerve damage. So here, glaucoma in the early stages have no symptoms. Gradually, once you start to have symptoms, your glaucoma is advanced. Just yesterday, I saw a patient and he said to me his eye was dark. And from the patient said to me his eye was dark, I knew that it was very likely that it was glaucoma because glaucoma damages your optic nerve. And so you have difficulty seeing things in the dark. Your dark adaptation is very, very much affected. So when rain sets and so on, you have very poor vision. And also, glaucoma is a disease that is very unequal, if you will. Maybe God in his wisdom, it tends to affect one eye more so than the other in the earlier stages. So you may have one eye that is severely affected, the other eye is not so bad, and that is why patients don't realize what is happening. So I saw a patient who, taxi driver no less, and he came and he said to me his eyes were getting dark. And when I did his visual acuity, and you know when you do your visual acuity, you cover one eye, and when I covered one eye, he said, no, you need to remove the cover because the eye that I wanted to check was completely blind, as in no perception of light, and he did not know. He had no idea that one eye was completely blind Because unless you cover your eyes and check individually, you may not realize that one eye is blind. And so he was totally devastated. Taxi driver and one eye. So his field of vision, entirely one side, was gone because it was blind. And you do not get back your sight with glaucoma. The vision loss is permanent. Your optic nerve is an outpouching of the brain. Brain tissue does not regenerate, and so you are not going to get back sight if you have optic nerve damage from glaucoma. The main treatment for glaucoma is to try to preserve the remaining sight. We cannot restore vision with glaucoma. We can only preserve what you have. So there are many treatment modalities for glaucoma. We use topical medication, we do laser, and we do surgical intervention of many types for glaucoma. So here, this kind of simulates what a person who has glaucoma, your peripheral vision goes. You tend to have some amount of central vision, and your vision, it's as if it closes in. So it closes in on you, and you start to get less and less until you have just your central vision. And a person with glaucoma walks a specific way, who has severe glaucoma. They see exactly what is in front of them. Their peripheral vision is gone, so they will look from side to side to see, because all their peripheral vision, because the peripheral nerve fibers, the rods, go first, and so they have their cones, and the central vision remains, and it's as if that central vision is snuffed out lastly. Now, diabetic retinopathy. I put diabetic retinopathy here because diabetic retinopathy, as we all know, it spans from childhood right up. I have written up, I've medical boarded so many patients because of vision loss due to diabetic retinopathy. And I tell patients when I see them that diabetic retinopathy is not an eye problem, it's a diabetic problem. But patients who have diabetic retinopathy will come to you late, and they think an eye drop will reverse it. It will just wash away retinopathy. No, it will not. Because high sugar levels damages the blood vessels in the retina. And when those blood vessels are damaged, they leak. They sometimes also get ischemic, and they close off the blood flow as well. And so you have ischemic areas in your retina. And it is a leading cause of blindness from ages, 30 upwards. And 40% of persons with diabetes have diabetic retinopathy. And there are no early warning signs. Okay, you've got to be examined when you have diabetic retinopathy. And the treatment options, again, we want to preserve sight. Treatment doesn't restore sight, we preserve sight. And so we have certain treatment modalities for diabetic retinopathy. We do lasers, we give injections in the eye, and we also do surgical procedures.
Dr. Mattis, an excellent presentation, but we have to wrap up.
Oh dear, oh dear. Can I quickly just go on to what we can do too?
Sure, go ahead.
Let me just quickly go on to what we can do. Okay, macular degeneration was done. So what I want to do here is quickly just tell you what we can recommend for good vision. You need to get your eyes examined, and you need to get it examined on a regular basis. And as I say here, if you smoke, stop smoking. And if you don't smoke, don't start. So we want to ensure that our medical conditions are under control. Okay? It goes hand in hand. You want to eat right. And I can't stress this enough. Eating right protects your vision. But I want to specifically stress here that, yes, we spoke, it was mentioned that we have supplements and so on, but nothing replaces our foods that we eat. And so we want to have foods that are rich in antioxidants. And so we have lots of foods here that are rich in antioxidants that are very good, because antioxidants mop up free radicals, which cause the aging process, the wrinkles and the so on and the cancers, etc., etc. So there it is. You want to keep moving. I can't stress that enough. You want to do regular exercise. and so on, because it's beneficial. It's a holistic situation. You want to wear glasses, of course, you can choose your style. You want to keep out ultraviolet radiation. You want to wear protective eyewear. Whatever you're doing, please, whatever age you are, please remember to wear protective eyewear, because you can damage your eyes. Hammering nails, you can lose sight from that. Can't stress that enough. Good sleep. You must remember a good night's sleep clears everything, and you want to sleep well to ensure you have resting of your eyes, your tear film layer, and so a good night's sleep augurs well for good vision. And I put at the end here, avoid your computers and phone screens before bed, okay? So in summary, I mentioned all of those things already, and that pretty much sums up what I want to say about our eyes. Sorry that I couldn't get into more detail, but basically, the important thing, as I said, is to prevent rather than to try and treat things that occur, inevitable things we know how to manage.
Thank you. Don't stress. Just find ways to live well and eat right, and you should be okay. Questions? I don't know if Sam would like to read the questions for us, please. Let me read the first one. I am 58 years old. Sometimes when I am reading or studying, I see a red shade. When it happens, I stop reading. Used to happen in my younger days too. Doc?
A red shape?
Shade.
Shade.
A shade of red? I didn't get that. I didn't get that clearly. What did the person see? A shade of red?
Yeah, a red shade. S-H-A-D-E.
Oh. Well, certainly sometimes when this is something that the person has had for many, many years based on what you said.
Yes.
So blood is something that is acute and is not something that is long-standing. Usually in the eyes, you tend to get a reflection from your retina coming off as a black color rather than a color, per se, red or blue or anything like that. So I'm not quite sure what that shape will be. I can tell you that certain conditions like glaucoma and so on gives your red, green, and your yellow, blue tinge a different shade. But I can't say specifically that a specific thing is just something that is of us, something in particular. Can't give you that answer. That
Do inhale corticosteroids
Sorry.
Do inhale corticosteroids for asthma and in nasal sprays or drops cause cataracts?
Well, let me qualify that. They are high risk. All forms of corticosteroids can predispose you. They're high risk. You can get a cataract from long-standing, and it will not cause it. Getting a treatment or a dose is not going to give you a cataract, but certainly prolonged use of corticosteroids, injudicious use, can predispose you. I've seen patients who have been using steroid eye drops for allergies for a long time, and they have a special type of cataract. I've seen patients and certainly you need your medication for your autoimmune condition. So I'm not knocking steroids. If you need it, you need it. And as I tell my medical students, you can't ignore treating your medical condition, because I've never seen somebody whose sight is preserved and they're dead. So you've got to treat what you need to treat. But as a side effect, or, you can get cataract formation from prolonged use.
I have one personal question. I have a patient that I looked it up who is on antidepressives, SSRI inhibitors, has done very well, but now has cataracts. And I looked up and it is a possibility. How often do you see it? And is it a class allergy if it happens?
No, I can't say I see it often. I know sometimes you can get pupillar dilatation from some antidepressant drugs where your pupil dilates, so you get blurred vision. So that is what I see more often. I don't see the cataracts as a cause. And certainly the age of the patient too is a consideration. Because if you're going to be over a certain age, as I said, I didn't grade or lens, if you will, but we can look at your lens and tell you your age. So I can look at the lens of somebody's not knowing the patient, see the patient's lens alone and say, okay, this person looks like about 40, 50, 60, or 70, or 80. So based on your antidepressant treatment, I don't know the age group but I don't know of it as a, something that I would say.
I have seen it before, but it is listed as a possible side effect, and she has done extraordinarily well on it. So I was not sure actually what to do, because her ophthalmologist also mentioned it could be causing it.
Well, if something has a risk profile, certainly one has to balance the benefit of the drug that you're using and the risk and what you can do. Certainly, if you have to use it and you develop a cataract, well, this is what you've got to do because you're going to develop a cataract from that condition. So it may warrant doing cataract surgery. So I would not tell someone not to use certain medication. Of course, there are other medications when we go into our, chloroquine and hydroxychloroquine, although hydroxychloroquine is quite safe because hydroxychloroquine or chloroquine, the precursor, could cause retinal damage, and which is irreversible. So you want to taper or manage that. But certainly, if it is a condition that is treatable, for example, steroids also can cause glaucoma. It can cause an increased pressure in your eye. But if I have to use steroids, I'm just going to add something to lower the pressure in the eye because I have to use a steroid. So when I say you kind of balance what you're treating and the side effects of certain things, that is exactly what you will have to do. But I would never tell somebody, don't use this because you're saying your patient is doing extremely well. I would certainly not tell you to take her off of it because she has developed a cataract. If she has developed a cataract, you're going to have to deal with the cataract. But certainly before you start the patient, you say, well, these are some of the side effects and so on and so on. But I would definitely not tell the patient, not prescribe it for the patient because you can have this side effect. And so certain things you have to say, well, this thing, you kind of work around it. But I definitely, in your case, would not tell the patient not to use their antidepressants.
It's good to hear two doctors discussing a case. All right, there's one other question, two other questions, and then we're going to go. I'm going to hand over to Dr. Lisa. Why would someone be diagnosed with dry eyes but yet have teary eyes?
That is always a question that the patient asks, because what your tear gland responds to certain things, and when your eyes get dry, you have the grittiness. You get water, and because of the grittiness, your tear gland, it's as if it's trying to re-moisturize that ocular surface because it has gotten very dry and gritty. But the tear gland produces mostly watery tears. The tear film has 3 layers. It has a mucoid component, which is the inner layer. There's in the middle layer, which is aqueous, which is more water. And then there's an outer layer, which is oils. Okay, and that oily layer is the stability layer that prevents evaporation. And so, depending on the type of dry eye that you have to manage it accordingly. So when you have that oily layer instability, you have to use certain types of treatment which helps that. But your gland is just going to produce more tears because it wants to re-moisturize. And the components of the watery layer is not going to moisturize your eyes, if you will. The tear film is a specific composition, and water alone does not lubricate. In the same way that if your skin gets dry, you don't use water to lubricate your skin, you use lotion. So you have to have the proper composition. And that is why it's a vicious cycle. Your eyes tend to be watering and it's not lubricating your eyes.
Question from the chat, from the Q&A. What are the main causes of vision loss in Jamaica?
Oh, the vision loss. As I said, we have refractive error, we have cataracts, we have diabetic retinopathy, and we have glaucoma. We have, glaucoma before diabetic retinopathy. Glaucoma is very prevalent, very, very prevalent. Only because, cataracts supersede it, because it tends to be, as I said, on the spectrum of physiological to pathological. And then age-related macular degeneration tends to be more hereditary. More Caucasians tend to get macular degeneration, very, very, very much so. We have it less in Jamaica, but we do see it.
Okay, last question, and then we move on. If we have time later on, we'll come back to some of these questions. But the last question I'd like to bring to you is, could problems with red and green vision be related to a genetic disorder?
Almost definitely. Red-green color blindness is an X-linked disorder. So you tend to see it more so in men because they will inherit that from their mothers. It's on the X chromosome. You're with me?
Yes, we're listening.
Yes. So it's definitely less, much less common in female, but you see it in males.
Okay, thank you very much for your very enthusiastic, passionate presentation on the subject area. I didn't know that eyes could get so loud, so soft, so wet, and so all the different things. So thank you very much. Yes. But don't leave, because we may have some more questions. Over to you.
Okay.
Over to you for the not you, but to Sam for the next set of
sponsors highlights.
Yes, sponsors highlights. Thank you.
Good afternoon, esteemed participants. I am Melanie Miller, medical representative for Medimpex Jamaica Limited for Western Jamaica. Here at Medimpex Jamaica Limited, our product portfolio is designed to meet a range of medical needs. Here is an overview of some of the products and their application. I'll start with the Mycocyst, which is fluconazole. Fluconazole is a triazole which inhibits fungal cytochrome P403A dependent enzymes, causing a decrease in ergosterol synthesis and inhibiting cell membrane formation. Mycocyst is available as both 150 mg strength and 200 mg strength. Here on this slide, you'll see a wide range of indication, the dosing regime, and the treatment of duration for persons who are using Mycocyst 150 and 200 mg. This is a presentation for Mycocyst 150 and 200 mg. Moving on to our other antifungal, which is Terbicil. Terbicil is available as Terbicil 250 mg tablets for adults and Terbicil Kid, which are 125 mg tablets for children. And it's also available in cream form. On this slide, you'll realize that the Terbicil tablets are able to treat conditions such as onychomycosis, whereas the cream is not effective in treating such conditions. Our next product here is the Midocalm, which is a muscle relaxant. The Midocalm contains tolperisone 150 mg. The dosing is 3 times daily.
Sorry, Sam, the screen is not changing.
Suffering from muscle spasm in locomotor diseases,
Sam?
peripheral vascular diseases.
Sorry, but the screen is not changing. I don't know if it's something wrong with the presentation or what.
It seems that that's how the presentation was sent.
Okay.
But
all right.
the audio is coming over?
Yes, very clear. That's fine. Continue.
Okay. Rehabilitation and also for neurological disorders. Moving on to our wound healing gel. This is Curiosin gel. It's added for those persons with diabetic foot ulcers, for persons with chronic wounds. Curiosin is on NHF and it can be found under diabetes and vascular. Our next product here is the Anodesen, which is a triple action hemorrhoid relief cream or ointment. It is available as a 25 grams tube.
Welcome to the world of Indus. And we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, Indus has grown from 1 to 120 products in 12 therapy areas. Today, Indus has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at Indus. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited Indus with many excellence awards like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana, and State Bank of India Financial Discipline Award. What's more, now Indus brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and GERD is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux and GERD lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux. As the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as GERD, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and GERD are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and GERD, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and GERD, Indus Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethicone. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. NewGel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimeticone in New-Gel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimeticone thus relieves flatulence. New-Gel is recommended in hyperacidity, GERD, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. New-Gel is available as New-Gel 200 ml suspension and New-Gel tablets with delicious mint flavor. New-Gel is safe in pregnancy. New-Gel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, Indus also presents New-Gel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. New-Gel O is available in 200 ml suspension with mint flavor. New-Gel and New-Gel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting Indus in our journey towards better healthcare.
All right. Thank you so much. We had some technical difficulties there. I know Melanie is online. Melanie, I'll try the video again. If not, are you able to share your screen? Are you there? Can you hear me?
Hi, good afternoon. Yes, I can hear you. And I'll be
Yeah.
able
Are
to
you
share
able
my
to?
screen.
All right. So if it's not too much, you could go ahead. I'm not sure what's happening with my PC with the video.
While we're waiting for Melanie to come on, can anybody tell me one of the products that was named just now from Indus? Anybody? Unmute your mic and say something.
New-Gel.
Pardon me?
New-Gel O.
New-Gel. Yes. Yay. Top of the class for you. Yes. 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 What about
Who was that? Who responded, Magdalena?
Pardon me?
Good afternoon, esteemed participants.
I didn't hear you.
Dr. Arnold.
Okay. So let me ask another quick question while we're waiting on the presentation to come. Just let me know.
Magdalena, may I have a suggestion? Since we're running late, why don't we work out the kinks in the presentation and add it on into the next set of sponsors highlights and then go across to the next session while we work out the bugs? Would that work?
I don't know if Melanie is just putting her things together. She's ready because she said she could do it. So
okay, Melody, are you ready?
I was just waiting. Okay, that's fine.
Go ahead.
All she needs to do was to just tell me that she was ready. So you can go right ahead and do the presentation. Sorry about the kinks earlier on.
Okay, good afternoon. Are you able to see my screen?
Yeah.
Loud and clear.
Okay. And you're hearing me loud and clear. All right. Good afternoon, esteemed participants. So again, I'm Melanie Miller, medical representative for Menopause Jamaica for the Western region. Here at Menopause Jamaica Limited, our products portfolio is designed to meet a wide range of medical needs, Here's an overview of some of the products and their application. So I'll move into the first product here, which is the Mycocyst. Mycocyst is the fluconazole, and it's our triazole. And with fluconazole, it inhibits fungal cytochrome P403A dependent enzymes, which causes a decrease in ergosterol synthesis and inhibiting cell membrane formation. So the Mycocyst is available as both 150 milligram strength and 200 milligram strength. And here we have a list of indications, including some skin conditions that the Mycocyst can be recommended for, the dosing regime, and the duration of treatment for these conditions. This is a presentation for the Mycocyst 150. So, and the 200 milligram strength. Next, we have our Terbicil, which is terbinafine, and it is available as both Terbicil 250 milligrams tablets and Terbicil Kid, which are the 125 milligrams tablets. The cream is also available. On this chart here, you'll see various conditions that the Terbicil can be recommended for. If you look closely on the chart as well, you will realize that the tablets are able to treat conditions such as onychomycosis, whereas the cream is not so effective in treating those conditions. Next, we have our muscle relaxant, which is Midocalm. Midocalm is a 150 milligrams tolperisone molecule. It's ideal for those persons with muscle spasm in locomotor diseases, peripheral vascular disorders, rehabilitation, and in neurological disorders. The dosing regime is 150 milligrams 3 times daily for persons who are taking Midocalm. The Midocalm is a prescription-only drug, and it can also be used in combination with NSAIDs. Here we have our Curiosin gel, which is our wound healing gel. So it's ideal for those patients with the diabetic foot ulcers, leg ulcers, for bed sores as well, superficial wounds. The Curiosin is available on NHF under the categories diabetes and vascular. Our Anodesen is an over-the-counter triple action hemorrhoid relief, and it contains allantoin, which shrinks the hemorrhoid, and lidocaine, which relieves the pain and irritation. Why triple action? It relieves pain, it soothes the itching, it promotes healing. Again, the Anodesen is an over-the-counter ointment, and it's a 25 grams tube. From Medimpex to the pharmacy, Anodesen is $510 plus GCT. On this slide here, we have our Sorbifol, which is our iron supplement. It contains 320 milligrams of ferrous sulfate and 60 milligrams of ascorbic acid, or what is otherwise known as vitamin C. So the Sorbifol, it uses a slow release technology. With this slow release technology, it results in lesser incidence of constipation and less GI irritation for patients who are taking it. They're ideal in size, they're odorless, and they're very affordable. Dosing is 1 tablet twice daily for patients who are taking the Sorbifol. And on the screen here, we have our wide range of Covonia products, from the Covonia Throat Spray, which is one of the more popular ones. And just to highlight that, the green box that you're seeing here, it was once in a yellow box. So the Covonia Chesty Cough, it was just a rebranding of the packaging. The formula remains the same, and it also contains paracetamol. Our Protect Orthopedic Support is another wide range of products that we have. Support for sprains and strains, support for weakened muscles and joints. And these are some of the products that are available. We also have them as ankle support, knee support, finger support. You name them, Medimpex will have them for you. These are the colors that you're seeing on screen that will be available in the pharmacies, and they're available in pharmacies right across Jamaica. Our Amlator here is the newest addition to the Medimpex portfolio. It contains amlodipine and atorvastatin, and it's ideal for those hypertensive patients and for patients with hypercholesterolemia. There are 3 strengths available for the Amlator. Amlator 510, Amlator 520, and Amlator 1020. Amlator is fully subsidized on NHF. These are the costs associated with Amlator from Medimpex and what the patients will pay once they have the NHF card. And this is for a month's supply. So this is a packaging for Amlator 510, 520, and 1020. Amlator can be taken any time of the day. So do recommend for your patients. It will increase compliance and also adherence in patients taking the medication, getting better control with hypertension and hypercholesterolemia. Thank you for having Medimpex this afternoon for this presentation. Good afternoon.
Thank you. Thank you very much, Medimpex. Excellent. I didn't realize you had all those products, and we definitely use them. Our next presentation is going to be understanding hair and skin changes at menopause and andropause and beyond. We have an excellent speaker, very accomplished expert. I'm going to try to shorten her biography, but if I leave out anything, please tell me, Dr. Green. Her name is Dr. Llorenia Muir-Green. She graduated from University of the West Indies with a double major in chemistry and biochemistry in 2002. She pursued a career in medicine at UWI and later went on for postgraduate specialization in clinical dermatology at Cardiff University, for which she graduated with distinction. She's a recipient of the 2013 Fellowship in Hair and Scalp Disorders at the University of British Columbia. She's a member of the American Hair Research Society, International Society of Hair Restoration Surgery, and a member of the Caribbean Dermatology Association. She is past president of the Dermatology Association of Jamaica, as well as an associate lecturer in dermatology at UWI. She's head of dermatology at Cornwall Regional Hospital, Montego Bay, where she conducts a once-a-month hair and scalp disorder clinic. She also has a hair loss clinic at the Derm Clinic at National Chest Hospital in Kingston, and she was the one that first established it in 2014. She has presented at various conferences. She has a keen interest in cosmetic chemistry and hair care, and she has an established blog on the science of hair loss and hair care. And her site is www.askthehairdoc.com. So askthehairdoc.com, and she will get back to you. She's also, of course, on Facebook, Instagram, and Twitter. Please welcome our very accomplished, busy expert, Dr. Green. You're great. Dr. Green, is she set up for sharing? I know I saw her here earlier.
I'm actually not seeing Dr. Green at the moment, but I know I saw Dr. Green earlier.
I saw Dr. Green earlier myself. In that case, while we find out what's going on with her, I'm gonna just say a few things. Now, I don't know, I saw something about when I was in college. Sam, find out if we can reach her, please. We know we have the next things coming up is density, hair.
Sam, I'm calling her.
Okay.
So sorry, there's no need to. She's
Afternoon,
here.
everybody. So
She's right here.
everything is
she's
sorted
back.
out right now. Here I am. So for some reason, it wasn't having me as part of Good afternoon, everyone. So for some reason, wasn't having me in as a panelist initially. So I'm here.
We do apologize. Same thing happened to me earlier. So we're sisters. So we'll wait on you, and you've started your screen sharing. Welcome.
Thank you for having me. I just want to thank everybody for staying for this long so far, and thank the committee for inviting me to give a talk regarding skin and aging. Hold on. excuse me.
I love skin, especially with all the pictures.
Okay, so today I'm going to be talking about the properties of the skin, skin aging, menopause and skin, andropause, and the skin and common skin issues in both sexes. So as you know, the skin is the largest organ of the body, and it serves several different purposes. Mechanical, thermal, prevents chemical trauma, protects against infections from microorganisms, and conveys sensory information, heat, cold touch, etc. Temperature regulation. And in, the most important thing when it comes to dermatology is, appearance to others. And that is one of the biggest things that most persons come to me or to most dermatologists at a certain age concerned about their skin and hair. So this is just a table outlining most of the what happens as we get older. And as you can see, there's a decrease in the skin lipid and barrier function, and that will result in dryness of the skin. Of course, there's also risk of overheating and stroke, especially in the very elderly. And as we all know, everything slows down and you get delayed healing and vulnerability to infection. So there are certain factors that affect aging and the skin. So the intrinsic factors are determined by genetics, and these are what intrinsically help to age you with time. And that is, as you know, most persons, they say black don't crack. There has been several genes associated with slowed or delayed excessive aging in people who are darker skinned or darker skin races, and including Black people and Hispanics and Asians. There is reduced hair, slow wound healing, collagen degeneration, and of course, as you know, photoprotection reduces more likely to get sunburn and skin cancer. Extrinsic factors include your exposure to the sun, UVA, which penetrates windows, so through penetrates glass, so your windows in your car can give solar elastosis and other aging or other signs of aging. Pollution, of course, plays a major role with respect to inducing oxidative stress and aggravated existing skin disease. Vaping and smoking, once you start to do that, reduces blood flow and you age significantly more once you do this on a regular basis. Diet, sugar ages the skin faster because it actually sticks to everything. So you actually get thickening of the skin, etc., when you eat a lot of sugar. Alcohol, of course, dehydrates the skin and reduces available vitamins. So this is just as the global scale for classification of photoaging. You don't really need to go into that, but this is what we tend to look at you when you come in and you're coming in asking about, can I get Botox, etc., etc. And again, another table indicating the difference between intrinsic and photoaging. So with respect to white people who are between Fitzpatrick skin types 1 to 3, there are two major types of skin aging that they get: atrophic and hypertrophic. And you will also see this, especially the hypertrophic type, especially in our albinos. The National Medical Association in this USA did a study on aging in darker skin types, which is from 4 to 6. And what they can say is that we get more hypertrophic aging. And unfortunately, I don't think this quite embodies, these pictures don't quite embody the kind of aging that we get, because if they were to add in our farmers, you will actually see even significantly thickening, lots of deep wrinkles for those persons who are exposed to the sun chronically. So when persons come in and, they come in out dark, what I can do for my skin, I want to do this, I don't want to do a little bit of that. There are lots of options available now. And some include laser, which is a fractional laser, ND-YAG for the discoloration, chemical peels. You may see online about the phenol deep peels, which gets rid of deep wrinkles, and that requires general anesthetic. Wouldn't recommend it for darker skin types because it causes a lot of issues. Of course, botulinum toxins, most of the brands that they have, Botox, Dysport, and Xeomin, they have been used to help with dynamic wrinkles. Hyaluronic fillers address the permanent deep lines. And recently, what have become quite trendy are the PDO threads, which give a temporary lift. So these are don't last as long, but you don't necessarily have significant downtime as you would get with a person who has done plastic surgery. Other things that can help with the photoaging: broad spectrum sunscreen, sun protection, of course, so it's staying out of the sun when the sun is at its highest, which is between 10 a.m. and 2 p.m. UV clothing. There's argireline, which is often advertised as liquid Botox. It is a peptide, and it has been found to help with helping mainly fine lines, and persons can use that over time and see some improvement. Of course, there is retinol or retin A. So tretinoin, which is our prescription vitamin A derivative, that has been used in anti-aging. The other one that also can be used for anti-aging, which is a topical retinoid, is the tazarotene. Alpha and beta hydroxy acids can be used. Those are your glycolic acid, lactic acid, malic acid, all of those things that you will often come across in the pharmacy when you're looking at these skincare products. Vitamin C serums, quite useful, and hyaluronic acid, which is pretty much in every moisturizer nowadays. Of course. So now we're going to go into what menopause and andropause causes. So for menopause, as you know, cessation of menses, and perimenopause can last anywhere between age 40 and age 55, average age 55. And what we know is that estrogen has direct effects on dermal health, because there are lots of receptors right throughout. Because most persons tend to forget that the skin is a major endocrine organ. And a lot of times when you're thinking, oh, it's just nothing, it's just a little acne or whatever, and it could be just meaning that something else is driving this, and it's one of the first things that you will see telling you that something is happening within. So with the cosmetic changes, of course, you get the loss of collagen, thinning of the skin, increased keratosis, skin atrophy, and hirsutism. And this is just to show you which are the estrogen hormones that actually affect the skin, and how they actually help with the skin health. So over time, as women get older, they lose about 30% of collagen within the first 5 years post-menopause, and thereafter lose 2% per year. Of course, you're going to get skin laxity, dry, coarse hair due to the reduction of estrogen. As you know, estrogen is one of the major causes of significant, wonderful hair. When women are pregnant, most women, their hair looks glorious. And with the change in hormones relative to testosterone, you can also get acne. So it doesn't necessarily mean that the testosterone is higher. It's just that because of the sudden drop in estrogen, you can have persons presenting at menopause with acne. And that, of course, as you would imagine, quite distressing. This just continues to show what happens with the elastin and collagen as you age, and with the loss of estrogen in time. So, of course, acne, very distressing. Can you imagine you go through most of your life, no issue at all, and then you come back 50 acne. You're like, what is happening here? Very distressing. So adult female acne tends to affect the lower half of the face. And again, it has to do with the relative rise of testosterone compared to the estrogen. And like all acnes, we will treat with topical retinoids. So the tretinoin, adapalene, which is a different, the tazarotene, which we used to have on the market, and or the over-the-counter retinol. Roaccutane, which is the oral version of which is isotretinoin, and benzoyl peroxide, topical and oral antibiotics. So again, lower half of the face is what we usually see with women with adult female acne. Female pattern hair loss, a major concern at menopause. And what we know is that there's no direct association with hormonal imbalances in women. They still haven't found which hormone causes it, but we know that it gets significantly worse around menopause. And it has to do with with the theory of the relative loss of the estrogen and its benefits on hair growth. Remember that female pattern hair loss is an inherited condition, and the amount of thinning that you experience is dependent on how many genes you inherit from both sides of your parents, from both sides. This is the type of the Ludwig classification of female pattern hair loss. This one is 3 stages, while you have the Sinclair, which has 5 stages. What you should note, though, in our population, Black women tend to have more male pattern type, where you get recession at the temples, along with some thinning along the top and to the crown. Treatment: high dose finasteride. You can also use the dutasteride, spironolactone, cyproterone acetate, saw palmetto for those who just want to go over the counter. And of course, there's minoxidil. Orally at low dose can be used for female pattern hair loss. Physical, we can use platelet-rich plasma, hair transplantation, wigs, and hair prostheses. For hirsutism, this is the male distribution of hair in a woman, and this allows, most common cause is in premenopause is PCOS. Post-menopause, there's a relative rise of testosterone, and also the adrenals can affect it. So treatment, eflornithine, which is Vanica, we don't have this out here. Laser hair reduction, doesn't completely get rid of the hair. You do still have to do maintenance on a yearly basis. Electrolysis is the only permanent way to remove hair, and useful for gray hairs which are not responsive to laser hair reduction. And of course, so we know the male distribution of hair. It can be the sideburns, the chin, the chest, around the areola, and the mustache. Andropause, often referred to as male menopause. No, as we know, there's no sudden drop in testosterone, and the prevalence is unknown, but what we know is that from about age 30, testosterone levels decrease 1% per year, and many present with late onset hypogonadism at age 60. So these are the symptoms that they tend to occur in andropause, and as we said, the testosterone declines over the decades. This is my dad with his male pattern hair loss, and what we know with male pattern hair loss is that up to 80% of men will experience some level of hair loss by age 30, 40. Well, more like in the 40s. Anytime you have somebody occurring in their teens and 20s, you have to ensure that they follow up with testing for cholesterol and their, same thing with women, cholesterol. But what importantly in men is that they start checking on their prostate from earlier, because these men are more prone to higher grades of prostate cancer when they compare to their other counterparts. So male pattern hair loss is due to the conversion of testosterone to dihydrotestosterone, and that is what shrinks the hair follicle, making the hair go thinner and thinner. And there are 7 stages. And treatment: low dose finasteride, 1 milligram, which is Propecia, which we don't have in the island. Or I tell persons to get the Proscar and divide it into 4 and take 1 tablet a day. And most men don't want to take it because of the potential risk sexual side effects. Low dose oral minoxidil has been used. Some palmetto, some other men also use it. Some persons use topical finasteride, which we can get some of the pharmacists to compound. And of course, there is minoxidil, which is usually the first line. Only problem with minoxidil for anybody is that you actually need to have an enzyme in the scalp to actually convert it to its active form. And you won't know until about 3-4 months afterwards that, okay, this person is not responding. But at least it's one of the cheapest ways to treat the person without going into all sorts of theatrics. And of course, with men, hair prosthesis, you can do hair transplantation, body hair transplantation, microneedling, etc. So what is common to both sexes? Xerosis. Mature skin can be excessively dry. There is reduced sebum. Dry skin is extremely itchy and can get secondarily infected if you're scratching all the time. So what you want to do is use soap substitutes, TP temperature showers, and hyaluronic acid lotions, urea creams, and anti-itch lotions. Some of them are on the market. I think Curel has one, and it has menthol and some other approxamine or something like that, which helps with the anti-itch sensation. So this is what that looks like. So discoid eczema is a coin-shaped scaly patches found typically on the limbs, mainly the legs, occurrence in men more than women, and it's quite itchy. We don't know why people get it, but age of offset is at over age 50, and it starts as red inflamed itchy bumps, which then become patches, and they tend to resolve on their own. So this is what that looks like. So this is in a darker skin. You can see it's coin-shaped and purple. So in darker skin, erythema tends to look more purple, and this is in a white or lighter skin person, and you can see the erythema there. So the treatment, mid to high potency topical steroids, emollients, the typical eczema treatment, and of course oral antihistamines. Chronic venous insufficiency, which gets worse as we get older. You can start from very early, but as you know, by the time you know, especially with the type of job that you're doing, if you're always seated or you're always standing in one position, by the time you're ready for retirement, you're more than likely going to have stasis eczema. And most of us have some amount of symptoms of the stasis eczema, with the pain and heaviness at the end of the day, swelling, cramping, pins and needles, etc. Stasis eczema, as you can see here, or gravitational eczema, you get the scaly patches on the distal leg, on the foot, and you can check for edema, etc. Of course, you're going to want to do leg elevation, wear compression stockings. Of course, I need to check on the pulses to see that they can tolerate compression. Greatest thing ever is, of course, the hesperidine diosmin combination, which is Daflon and the Divinis, and those help with the symptoms and help with the inflammation in the micro circulation. Cherry angiomas is a small papillary angioma, and they're quite asymptomatic form. They're either red, blue, or purple, and it is a true capillary angioma and markedly increased after the age of 40. And this is what these look like. So you may see them randomly. We don't really do anything to them. We just leave them alone. If you want to take them off, we can burn them off for you, but they're quite harmless. Dermatosis papilosa nigra. These are commonly called warts in Jamaica. They are not related to HPV in any way, shape, or form. They are identical to seborrheic keratoses, and approximately 40 to 50% have a family history with it. So at least one person in each generation, and it's usually autosomal dominant transmission. It is believed to be a nevoid developmental defect of the hair follicle, and it is hormonally responsive. So you will see persons complain that they got a whole heap when they got pregnant, or they started the contraceptive pill. And if I see a person coming in saying that they suddenly develop a whole bunch of them in a short period of time, I will actually do hormonal testing on that person, even if it's a man. Treatment, we can do electrodesiccation, curettage, we can cut them off, etc. Of course, Morgan Freeman here, his own, as they get older, they get bigger. So his own were quite flat when he was younger. If you look at older photos of him, you're going to see that they're quite flat. As he got older, they got quite big. So these are what these are, and these are what we call the warts in Jamaica. So seborrheic keratoses, these are brown warted lesions that are usually about 1 centimeter in diameter, and it's associated with skin aging, occurs in all races and sexes, and more prevalent in persons over the age of 60. May arise in skin folds due to friction, similar to what happens with skin tags, and rarely it can develop into squamous cell carcinoma. They can become eruptive, as in sudden onset of a whole bunch of them coming up after a recent sunburn or radiation dermatitis, which we have one of our patients with that, or it can be a paraneoplastic clause, and we may have to, if there's no other obvious connection, and we have to do a check for gastric adenocarcinoma, we can do curettage, shave excision cryotherapy. And these are what those look like. And these are more common in whites and Asians and Hispanics. We're not as common as in Black people, but we do get them. Idiopathic guttate hypomelanosis, also called age spots. These are a common cause of leukoderma or whitening of the skin, and they're non-scaly, hypopigmented, or depigmented, affects all races, skin types, and ages, and affects races, sexes equally. Multiple factors contribute to developing these lesions, but what happens is that they occur in all races, but they're more obvious in darker skinned persons. Very uncommon in children and teens, and usually start to develop a lot more in your 4th and 5th decades. If I see somebody who comes in with a sudden eruption of these, I have to do thyroid, adrenal, or autoimmune testing to make sure they're not having some other condition while making them develop so many at once. Treatment is kind of difficult. You can use tacrolimus ointment, topical retinoids, and chemical peels to help with them. And these are what these look like. So you get these little hypopigmented small macules, not the greatest here on magnification, but these are what those look like. And typically you get about a few per year. Again, if you see all of a sudden several coming up at once, then you need to be investigated. Plantar hyperkeratosis, which is an acquired keratoderma, more seen in obese individuals, and it directly results from pressure effect. In menopause, it's called keratoderma climacteric, and you get the hyperkeratosis of the palms and soles, more soles than the palms post-menopause, and it is a sign of impending diabetes, hypertension, and obesity. Treatment, keratolytics, which is salicylic acid, you can use urea creams, etc. And this is what that looks like. Solar lentigo, also known as sunspots, are flat, tan, dark brown to well-circumscribed patches, more common in whites, albinos, and lighter-skinned individuals. And they are round, oval, or irregular in shape. And sometimes seborrheic keratosis can arise from them. They can develop into lentigo maligna, and I advise persons to do yearly mole checks for especially if they have them, and a treatment, sunscreen, so that it prevents new ones coming up, cysteamine creams, which we don't have out here, chemical peels, and laser therapy can be useful. So these are what that looks like. So when persons come with these, I actually have to examine with a dermatoscope to see if there's any part that is, suddenly getting darker, and they might be developing melanoma. Skin cancer occurs in all races, more common in whites and albinos of all races, and photoaging is greatest contributor to skin cancer. Most of them develop from, copious amount of exposure to the sun, especially those who have sustained sunburns, frequent sunburns, or sunburns that are horrendously painful in the past. They can actinic keratosis are the precancerous lesions. They're felt more than they actually are seen, and they're often called rough spots, and most commonly occur in the sun-exposed areas. They can develop into squamous cell carcinomas, and what we can do is photodynamic therapy, use of Aldara, Effidex, and solar rays, and cryotherapy. These are what that looks like. As you can see, some of them not so obvious. You actually have to feel them more than you actually see them. Basal cell carcinoma. These derive from a DNA mutation in the patch tumor suppressor gene, and of course, triggered by past sunburns, etc. They're actually quite slow growing, and they're not likely to spread compared to all the other skin cancers. And we can use Aldar for them for the superficial nodular and nodular basal cell carcinoma. We can use Efidex, curettage, and most surgery. And these are what look like. So this is I think a Fitzpatrick type 4 person. In darker skin, they tend to be more pigmented. Squamous cell carcinoma is the second most common non-melanoma skin cancer and can metastasize, and they're more deadly than BCCs. 90% are due to DNA mutations of the p53 tumor suppressor gene, and there are those who develop de novo. Now, you can have associated with HPV, and I think some of the ones that we have out here could be due to those. Unfortunately, we haven't tested them. So they're quite high risk, higher than the basal cell carcinoma, and you actually have to check for metastases. And there are various ways to remove them. And this is one of our patients in the clinic that we have, as you can see, quite irregular looking. The patient had it for about 10 years, lovingly dressed in the health center, and somebody had the fortitude, wherewithal to say, no, let's send him to dermatology clinic. And yes, he had squamous cell carcinoma. And these are what they also look like. Again, they can come from or arise from actinic keratosis, and especially if they're left on for a very long time on the skin. Melanoma, this is the more aggressive, the most aggressive skin cancer, and they can be sporadic, most of them sporadic, and some of them are inherited. And you have different types, and the most important one is the acrolentigenous, which is the most common one in Jamaica. All the others usually come from moles, but in our population, these are the ones that, everybody come in, oh, I have a bruise on my foot, and it's actually melanoma. This is what you need to remember about melanomas, the A, B, C, D, E. Is it asymmetric? Does it have even border, uneven borders? Does it have different colors? It is larger than 5 millimeters. Well, this is 6 millimeters, but 5 millimeters. Is there an evolution of growth so that it's actually changing over time? And you excise them. You can do immunotherapy, radiotherapy, chemotherapy. And this is one of our patients who's no longer with us, because by the time he came in to see us, he would have had it for about 10 years and was also being dressed at the health center, unfortunately. So thankfully, we're now doing training throughout the entire region, and getting persons more aware of what these things look like. And that is it. I hope I made up for time.
Thank you, Dr. Muir-Green. Excellent, excellent presentation. I think we had a couple questions. Sam, do you want to read them? All right, I'll read one that starts. Go ahead. Do you want to go ahead, Sam?
So I was saying there's one in the Q&A. How does one determine that plantar fissures require antibiotic treatment as opposed to antifungal therapy? That's from Andre Shepy.
So for fissures in the feet, they tend to be quite painful, and they respond quite well to the antibiotics. If you are thinking about fungal therapy, you're usually looking at, you would actually have to look carefully and see if there is pinpoint scaling, as you would see on the soles of the feet, or you'll see scaling between the toes. So if all they have is just the thickening of the skin or the thickening of the sole with just the fissures, then it's more than likely the keratoderma. But if you notice as well pinpoint scaling or a lot of flaking coming from the feet, or scaling or maceration between the toes, or you more than likely it's actually from tinea pedis.
Thank you so much. What is the best treatment for cellulitis?
So cellulitis always should be IV medication. Your broad spectrum beta lactam with the augmentin should be the first line. you can consider others depending on if the person is allergic to those, but that's the first treatment.
All right, and then I have, are there any concerns regarding skin tags? I'm assuming long-term or life-threatening concerns.
So with skin tags now, not necessarily. Some of them can suddenly all of a sudden develop and grow quite large pretty quickly. Those persons, they just take them off because those, if left long enough, can become cancerous if you leave them for like decades as well.
Thank you very much.
One of our panelists, though, had one on, you just shifted it. Well, I think I remember saying what she asked, what are the small white spots that show up on the legs and arms? It's from one of our panelists. Did we lose her? Ugh. Sam, did we lose Dr. Green?
Unfortunately, yes. I'm not sure why. Perhaps internet, which is strange because it was so stable. I'm not sure.
Well, excellent presentation. Since we can't ask any more questions because we lost her, maybe at the end, if there is an excellent one that got missed, we can add her again if she comes back. But next, we're going to go to our sponsors highlight. I think next is National Health Fund, and I think they're coming to us in person or online. We're not pre-prepared.
Online?
Yeah, but they're gonna talk to us. Welcome.
Okay, good afternoon. Masters of Ceremonies, Dr. Lisa Kervin Dawes, Dr. William Brown, President, Professor the Honorable Earl Morrison, and co-founder and Honorable President of the Diabetes Association of Jamaica, other medical professionals, present partners, sponsors, and especially invited guests, ladies and gentlemen, good afternoon. It is indeed a pleasure for the National Health Fund to be here. Commendations to the leadership of the society, Dr. William Brown and Dr. Lisa Dawes, executive members, and the wider team for the invaluable work you do. Also to the key partners, other presenters and sponsors, thank you for your contribution to healthcare. Greetings to you all on behalf of the Board of Management and staff at the National Health Fund. I am Sharon Jones, Manager of the Health Promotion and Public Relations, and it is my pleasure to present the NHF in this webinar symposium. What founded in 2007, I think your work presents a significant step in understanding the issues surrounding midlife and beyond, and you constantly develop various strategies to encourage individuals in this age group to live their best lives. I want to also commend you on hosting 3 webinars since the start of the year, and we're very happy to be an ongoing sponsor and partner in health. The National Health Fund is keen on reducing the burden of healthcare for the population, and as such, for the past 20 years, we have made significant investment in public health covering drug subsidies, infrastructural development, health promotion, medical and non-medical, special projects, and training. And I know in June when we presented on the increased subsidy for over 380 pharmaceutical items across 8 conditions. Additionally, in September, the PSA test was also added with a $1,600 subsidy on the PSA test at select labs across the island. And today I am very happy to share another great news as the NHF has further expanded the NHF card program offerings to 5 new conditions, namely multiple myeloma, lung cancer, colorectal cancer, thyroid disease, and Parkinson's disease. So as of October 24, 2003, these 5 conditions are now available for our beneficiaries. This means that the NHF now covers 22 illnesses, and we are very happy that we were able to add these conditions on the NHF card program. We have gotten a lot of reviews in terms of a long time coming. Persons have been advocating to add these conditions for quite some time. So over 10 APIs are available for the treatment of the 5 new conditions, and the full subsidy listings are on our website. The application form has been revised as well and can be downloaded from our website as well. So we are encouraging persons to take advantage of these new conditions by signing up your patients to access the benefits. The addition of conditions really is a symbol of our continued commitment to greater access and sustainability for the Jamaican health population in our 20th anniversary year and beyond. And in keeping with our strategy priority, the NHF is committed to periodically reviewing the needs of the healthcare sector and make the necessary changes in an effort to remain relevant and maintain the access of medicine. So in closing, we want to encourage everyone here, especially the physicians, to promote the new services of the NHF and to encourage as many persons as possible to get enrolled on the NHF card program to access these new benefits as well as the existing ones. So I thank you so much for having us, and it's always a pleasure to partner with you. Thank you.
Thank you, Ms. Sharon Jones. It's always a pleasure as well. And all of us use NHF because it does decrease how much we have to pay. And the prices of medicines are expensive. The next one, Sam, I think that is a pre-prepared slide from Jamaica Observer. Correct me if I'm wrong. If not, please
Hello,
start.
attendees of the Jamaica Midlife Health Society's 3rd and final webinar symposium under the theme, Impact of Menopause and Andropause on your aging eye, skin, and oral health. We're excited to join in on this informative session, and we hope you all have been enjoying the session so far. First and foremost, we would like to express our gratitude to the Jamaica Midlife Health Society for inviting us to be a part of such an important initiative. And today, we have a special announcement for you. Now, the Jamaica Observer, as I hope you all are aware of by now, is a trusted source of news and information, and we have made it easier than ever to access our content. Our e-paper app is a digital platform that allows you to read the newspaper conveniently and efficiently on your digital devices. Cool, right? But what are the benefits? You must be wondering. Well, for one, you can access the newspaper anytime, anywhere, right at your fingertips on your smartphone, tablet, or computer. Convenient, right? Not to mention, the app provides an interactive experience. So that allows you to easily navigate through articles, zoom in on text and images, and even search for specific topics. If you're a sassy babe or a business exec or health enthusiast, then there is no need to scroll for minutes to find what interests you. We love a good time saver, don't we? And last but absolutely not least, archives. Yep, that's right. The app provides access to past issues, making it a valuable resource for research and reference. So, for those who hate to take a stroll to the libraries that are limited by their operating hours, you have 24/7 access to the archives in the app. Now that you have been sold on the app, you need to know how to get started, right? So, here's what you need to do. Download the app. Just visit your app store, whether it's the Apple Store or Google Play Store, and search for Jamaica Observer e-paper. Install the app on your device. Register for an account with the app. Register for an account with the app. This will allow you to personalize your reading experiences, so you might want to do this for sure. Then there is subscription. You may need a subscription to access all the content, but don't worry, we offer affordable rates with subscription options to suit your preferences. And with that said, we do strongly believe that the Jamaica Observer's e-paper app will be a fantastic addition to your digital lifestyle, providing you with the latest news, updates, and insights at your fingertips. We encourage you to download the app and explore the convenience it offers. And of course, feel free to contact us if there are any additional questions or concerns. But once again, we want to express our sincerest gratitude to the Jamaica Midlife Health Society for having us, and we look forward to your continued partnership in our future events. We hope you enjoy the rest of the symposium and happy reading with the Jamaica Observer's e-paper app.
Thank you very much from the Jamaica Observer. I was just asking if we had any specials, but I heard that we should watch the chat because somebody might win a 3-month subscription for the Observer e-paper. Dr. Green just came back. What I'm going to ask is that we probably ask her if she can stay to near the end for the questions for both the dentist and her. And I would turn it over to Miss Magdalene Cooper Deleuze, the news.
Okay, thank you, Dr. Lisa. It's now my pleasure to introduce our third and final presenter. I'm just putting up my screen share now. Hope you all can see it. And can you all see this screen? Yes? Okay. So our third and final presenter for today is Dr. Sarah Tibby, dental surgeon. Dr. Sarah Tibby has always been fascinated with the field of dentistry. Her close friends from St. Andrew High School were so aware of her passion that her fleeting interest in becoming a pediatrician was quickly discouraged. Pursuing a lifelong passion for dentistry, she earned her Doctor of Dental Surgery degree from the University of the West Indies, Mona campus, shortly after she graduated from Randolph College in Lynchburg, Virginia, USA, with a Bachelor of Science in Biology and Mathematics. During her tenure at both institutions, Dr. Tibby received awards for outstanding leadership, volunteer service, and academic performance. Dr. Tibby works as a dental surgeon at Dent Care Smile Clinic, and I've put the Facebook on there, link that you can go in and see it and get more information on the clinic. And also the numbers for the clinic, I've put it there as well, 9260579 and 876-906-4211 after hours emergency. She's an active member of the Jamaica Dental Association who combines her love for dentistry and volunteerism by participating regularly in dental outreach, giving persons the smile they deserve, taking a keen interest in treating children. Besides her professional activities, here's what she enjoys. She also enjoys tending to her orchids, planning and implementing events, and traveling. Our topic this afternoon is maintaining your best oral health at midlife and beyond. Over to you, Dr. Sarah Tibby.
Thank you so much for that introduction. I hope everyone is still attentive and ready to go for the last presentation. And I hope I will be really quick so that you have enough time to eat your dinner and watch a movie. All right, let's jump in. Are you able to see my screen? If you're able to see my screen, give me
Very
a
clear.
reaction. All right,
Yes.
awesome. So maintaining your best health at midlife and beyond. That is our topic today. And I'm gonna touch on a few areas, but I want to start with just describing the oral cavity and its surrounding structures. So we're all seated, and I'd like you guys to participate if possible. And just take a look, if you can, with your phone or a mirror nearby, and And turn your cameras facing and smile. Yeah. Think about your smile. We're looking at the teeth. If you open nice and wide, you see the tongue. If you go all the way back, you're gonna see probably your tonsils, the uvula hanging down. And when you gargle, that's the part that shakes and wiggles. All right, thank you God for the rain. Now, apart from those structures, we have the teeth, which are embedded into the gum and supported by bone. So if you hit the side of the jaw, it's pretty hard. And that is because the jawbone is tough, 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 tough. So we've talked about the teeth, the gum, the jawbone. Let's talk about what's hiding under the tongue. So if you lift your tongue to the roof of your mouth like this, you will realize some saliva is squirting out. Or perhaps you don't have the saliva squirting out, no problem, but the floor of the mouth rests right below the tongue, and we have some salivary glands existing there. Now, to properly maintain our oral health, midlife beyond, there's a key element, and it's brushing. So the first thing on the list that we need to ensure we're doing is brushing twice a day with a soft toothbrush. Now, why not a hard or why not a medium? The hard and the medium tend to destroy the surrounding structures of the teeth, and we'll talk about that further along in our presentation. Now, brushing as we get a little bit more mature can become a little difficult. So for those of us with RA, osteoporosis, or any joint, any issue that affects the joint, sometimes we have a hard time really gripping the brush and reaching the hard to reach places. No worries, I have some recommendations. The first one would be a battery or electric toothbrush, photographed right here on your screen. And this will allow less dexterity use, and it's a little thicker, so you can grip it a bit easier, and it does the work for you. You just have to move it around your mouth. We have the triple side toothbrush, which is up top here. And what that does, brushing, is a lot less in time. So in case your TMJ is affected, you don't have to open for that long because all surfaces of the teeth are being targeted at the same time. And lastly, another recommendation is the assisted handle. With the assisted handle, primarily for geriatric patients, the toothbrush is wrapped by a washcloth or a hand towel, and this gives you a thicker grip or something thicker to grip, and it's a lot easier to brush. Photographed here is actually a product that's on Amazon that you just slide the toothbrush in and it allows you to grip very easily. In addition to brushing twice a day with a soft toothbrush, flossing is also recommended to maintain your best oral health at midlife and beyond. Now, flossing may seem so simple, but it goes a very long way. You have different types of floss as well. So the whole point of floss is simply, I'm just gonna use my finger as a tooth and show you what the flossing should look like. This is what most of my patients say they do. Oh, doc, I just pop it in between the teeth and, you know, a floss, man. That's not flossing. So what the floss should actually do is go in between the teeth and hug the side of the tooth and come up. In between, hug the other side and come up, and then the adjacent tooth, the same thing. So it's actually a motion where you're removing the plaque or food deposits in between the teeth and not just popping in between. All right, so that's the proper floss technique, so that you're actively removing the plaque and the food. Now, again, if you're not able to do the traditional floss, there are other methods. If you have a bridge, if you have braces, super floss, which is at the lower end of your screen right here, would be the recommendation. It just slides under the bridge, in between the brackets and the wires, and allows you to floss effectively. Older patients tend to have a harder time removing food deposits, and we have water flossers now on the market up top here. It just blasts, the tip literally goes along the gum line and along the teeth and blasts away all the plaque, or most of it in fact, and allows the patient to have less food particles in the mouth, allowing for less bacteria and the prevalence of gum disease. So let's continue. Another way to ensure our teeth stay healthy is to fortify our teeth with things that give them muscles, strengthen the enamel. What helps to strengthen the enamel? Fluoride is an agent that helps to strengthen the enamel. Fluoride is found in toothpaste, mouthwash. Here in Jamaica, we have salt fluoridation. In other countries, it's in the water or in milk. If you don't wish to use fluoride, no worries, that's okay. You can reduce the amount of bacterial load by using xylitol products. So xylitol is a great substitute, chewing the gum, using the toothpaste, using mouth rinse, and it doesn't exactly kill the bacteria, but it surely slows the rate of the bacteria's ability to multiply and stick to the teeth and therefore cause cavities. In addition to all of those things, a healthy diet. This is just so important. Now, dental issues can be really extreme in the presence of sugary drinks. So soft drinks, energy drinks, they all help to promote bacterial growth. The bacteria are just happily in the mouth waiting for the sugars to just come, and they feed on them, produce these acids that destroy the teeth, the gum, and later on the bone that supports the teeth. So the idea is to maintain a healthy diet, some grains, vegetables, fruits, meats, beans, balance it all out. If you're snacking, try to snack less during the day, ensure the nighttime brushing is done, and then you'll be able to live a happy and healthy life. One very important thing, and I left it for last on the list, is to visit your dentist twice a year. Why? You will take x-rays and you'll be able to see what lies in between the teeth. Now, I have patients who are always looking in their mouth, which is great, but unfortunately, these cavities that exist between the teeth are not visible upon clinical examination or just looking in the mouth. You actually have to take x-rays to evaluate. Another reason why x-rays are important is that you get to assess the bone height and also see if you have any buildup underneath the gum, which dictates the type of treatment that you require. So here in this patient, they have a filling on the lower left molar, and they have a couple cavities in between the teeth. Here's one, this little gray mark here, a much larger one here, some buildup hanging off of the gum, and a little drop in the bone height. And as you can see, this tooth is missing. So for a patient like this, we'll discuss replacement options, getting some fillings done, further testing this tooth to see if it may need a root canal treatment or if it's okay to just go ahead and fill it. In the other slides, we have an extraction being performed, and for orthodontic reasons, this patient came in for this extraction, and I decided to record it for the purpose of science. No problem, I can use it in my presentations. So at some point in time, the orthodontist would send over a referral and say, hey, I need some more space in this mouth. Can you do some extractions for me? And then we perform the extraction. Unfortunately, the patient in the middle of the slide here presented with oral cancer. So an examination was done, and based on the appearance, we referred to fossa, I believe, and the biopsy came back, squamous cell carcinoma, and the patient received treatment at their facility and is doing quite well. The patient to the lower right of my screen, right here, lots of deposits on the tongue. The lips look chapped, some fractured teeth, and very inflamed gums is how he presented, and he was not yet 40. Now, when a patient presents like this, we usually refer to the physician to have some blood work done because they have the possibility of being immunocompromised, suppressed. Something is going on that isn't right. In this particular patient, he was actually diabetic, but he just didn't know. So it's very important to visit the dentist because you won't know these things are going on, or you won't know the causes of it. Sometimes it requires a further step. So oral health and midlife. Before we jump into that, we have to understand that there are, as you age, things that can happen to some people. So it's not everybody would experience the following. So teeth can become yellow, especially if you are doing coffee every day and you're not visiting the dentist routinely to have your cleanings done, or if you have a heavily acidic diet, or if you're experiencing thinning as a result of the diet or medication, brushing too hard, etc., bruxism, all of those things will cause the enamel and the dentin, or the enamel, to wear away, exposing the dentin, which would result in yellower teeth. Also, with grinding and clenching of the teeth, you will have shorter teeth, and of course the dentin showing through. With continued and prolonged hard toothbrush use, you will develop recession, or the gum line just pulling away, exposing the root structure of the tooth, which is yellow. You also have an increased risk of developing periodontitis and gingivitis, and we'll talk about that after, as well as decreased salivary flow, and all of these things can lead you to developing cavities and losing your teeth. So let's talk about the first one, tooth wear. This particular patient perhaps had a history of using the front teeth a little bit more often to chew because they don't have the full complement of posterior teeth. And what happens there is that they continue chomping all these hard foods with the front teeth, and over time they become tired, they stress out the enamel and say, I can't manage no more, and go. Another thing that can lead to a presentation like this is bruxism. So grinding the teeth, especially at night time, can lead to this presentation. Right here in the lower anterior, we actually see the roof of the nerve, and that's a result of the enamel that should have been here to cover the dentin that is now exposed. All right, along the gum line, we can see some recession. And what can prevent this? First of all, our diet should not be so hard. So the bottle opening is a no-no. Here in Jamaica, persons using the teeth to peel cane, no thank you, knife is just fine. And stress management is always recommended. If you find that you're grinding or clenching, or if a patient of yours is doing that, a mouth guard, photographed here, can be made for them, or you can get it over the counter at any pharmacy. And of course, a soft food diet is recommended, granted the patient is presenting like this. Now, yellowing of the teeth can be caused by various factors. So we have the coffee, we have developmental disorders, that this patient here on the top, right? She was born with the teeth like this. She said that they just appeared this way when she was around 8 or 9, and growing up, she realized that they all had it. So it's pretty much a developmental disorder that she had. And she wanted a natural look for her 45th birthday, and she said she didn't want to do the veneers route, which is photographed in the middle here, where the lab makes it and it costs a whole lot of money. She just wanted her natural teeth to look a little better. So what we were able to do for her is called a composite veneer. So it's regular filling material placed over the teeth, and of course it's a more natural finish. Now, her teeth could not be whitened. If based on examination, the yellowing is just natural teeth yellowing, then a whitening can be performed. But in her case, a whitening would not have treated her tooth discoloration. The photograph in the middle, as I mentioned before, this person opted to do veneers on their front teeth and ended up with a much nicer result. Let's go back to gum recession. So remember, the soft toothbrush was recommended, and here is why. This patient now presented with a whole lot of recession. So this is a gum on the side of the teeth here. And yes, they tell us the harder the toothbrush, the better, but it's not so it go at all. Brushing should be done in a circular motion, or some persons prefer up and down, not this. What this action does is tear away the side of the gums, leading to recession. Recession can be treated with fillings. That's what's photographed here on the left. Or if it's really, really severe, you can consider a gingival graft. With a gingival graft, there's gum that is harvested from the roof of the mouth or elsewhere in the mouth, and surgically placed on the side, leaving you with a beautiful result as if nothing happened at all. So let's jump into gum and bone disease, and I'm going to play a short video.
Did you know gum disease is a leading cause of tooth loss in adults? Gum disease begins with plaque, a sticky, colourless film that constantly forms on teeth. Plaque contains bacteria. If not removed with daily brushing and flossing, plaque can build up. The bacteria in plaque releases toxins that irritate gum tissue. This condition is gum disease. Left untreated, gum disease can progress and lead to bleeding, tooth loss, and damage to bone and mouth tissues. Gum disease has 2 stages. Gingivitis is the first. Gums are mildly inflamed, can appear red or swollen, and may bleed during brushing. If detected early, gum disease can be reversed. Periodontitis is the second stage. Gums begin to move away from the teeth, allowing plaque bacteria to move close to tooth roots, supporting fibers and bone. In advanced periodontitis, supporting fibers and bone are destroyed, teeth become loose, and they may need to be removed by a dentist. See your dentist if you experience any of the following: gums that are red, swollen or tender, gums that bleed during brushing or flossing, gums that have moved away from teeth forming pockets, changes in the way teeth fit together when you bite, persistent bad breath, or a bad taste in your mouth. The good news is that gum disease is preventable, and everyday toothbrushing, using the right toothpaste and toothbrush, flossing and professional cleanings as advised by your dentist can help prevent gum disease. Remember, taking care of your gums will ensure your teeth will last a lifetime.
And that's exactly what we want. We want our teeth to last a lifetime. So just touching briefly, gum disease has been linked to systemic disease, and I'm going to touch on probably just diabetes today and mention that periodontitis does affect diabetes. So imagine you have a lot of sugar in the blood that contributes to bacterial overgrowth. So if you have periodontitis, you have a lot more bacteria, and then increased sugar in the blood, you just have even more bacteria forming and overgrowing in the mouth, and then it's harder to control both diseases as a result. Now, women who are going through menopause or postmenopausal have suffered some sort of tooth loss because of the limiting amount of bone in the mouth. Research out there shows that. And one last thing, heart disease. So within the pockets that form as a result of periodontitis. So periodontitis causes the gum to shift away from the roots of the teeth and little pockets form. Within those pockets, you have bacterial plaque, photographed here, and red inflamed gums. Blood is everywhere. Sometimes patient may brush and I say, boy, my gums keep bleeding every time I brush. And when you take a look, a lot of pocket formation and a lot of inflammation. When that happens, the bacteria from the mouth can dislodge and enter the bloodstream and then lead to cardiovascular issues. So it's very important to prevent. And if you do in fact have a patient with periodontal problem, they need to just go to the dentist, whether a periodontist, who is the specialist that deals with the gum and the bone, or a general dentist, or the general dentist with a hygienist. Any one of those persons can help with treatment. What they would do is a full periodontal exam, which includes x-rays and measuring the pockets, etc., and then treat with a special type of cleaning. That cleaning removes the cementum from the root that is diseased, allowing for healing, and then they're monitored. So if it is that the cleaning does not help, the specialized cleaning doesn't help, then surgical interventions may need to be done. Now let's go to another possibility during midlife and after that can arise, and this is dry mouth, formerly known as xerostomia, and it's usually induced by antihypertensives, antidepressants, chemotherapeutic agents, radiation treatment that has affected the salivary gland, and it makes the patient's lives miserable. So imagine if your mouth is dry. You tend not to want to eat the foods that make it even worse. So if you used to love cheese and crackers, cheese, no problem. But then when you put the crackers in the mouth, it just doesn't taste the same. And patients will complain about that. Their ability to tolerate a prosthesis, so putting a denture in the mouth may be a little harder because the lips become so dry, it's harder for them to put in the prosthesis. So it changes their quality of life. How do you treat dry mouth? You can recommend salivary substitutes or stimulants, and of course, increase water intake. Most of these saliva substitutes include xylitol, which helps to improve saliva flow and stimulation and also reduce bacterial load. For the lips, we can recommend petroleum jelly just to keep them moist, but nothing beats water. Now for dentistry, the sooner you tackle the problem is the better the prognosis. So here you have a nice healthy tooth. When it's at this stage or this stage, you can probably do a filling, but when it gets to this stage, it's a root canal treatment. When it gets to this stage, it's a root canal treatment plus crown lengthening plus a crown, and when it gets to this stage, it's an extraction. So the idea is to get to the issue before it even becomes problematic or costly. Don't wait until it's too late. That's the encouragement to the patient today. Here's an X-ray of a patient who came who was just having a toothache in their wisdom tooth, not sure why. We did a couple of tests and I said, you know, this tooth is likely to be cracked. And of course, we have to take it out. It did not respond to hot or cold tests. The tooth was pretty much dead. And being dead, the nerve inside of it died and the surrounding structures were affected. The patient's X-ray also showed that they have periodontitis. May have been controlled because we're not really seeing any buildup along the sides here in the X-ray. However, when we took the tooth out, if you look closely, you see a small line running in between the tooth hair. And this is a gingival tissues right here and a small abscess here at the root. When I took it out, I decided to just touch that line and lo and behold, the tooth was fractured. How did the tooth become fractured? What's the diet like? Oh, I chew bones, love bone man, love ice. Advise your patients not to chew those things because it can lead to fracture. Now, alternative to extraction is root canal treatment, and it tends to be a little taboo in a lot of persons' minds, but root canal treatment has been proven to be safe. My only recommendation after root canal treatment is to get a cap or a crown once the tooth needs it, because that will maintain the structural integrity of the tooth. What a root canal does, it takes out the life out of the tooth. So you remove the actual nerve, which is what is being photographed here, and you fill the tooth so that you can preserve the tooth structure. So preserving the tooth structure is maintaining bone height, and we'll talk about why that is important, and also allowing you not to lose your tooth. But you must protect the tooth by capping it with a crown. With aging comes increased risk of developing cavities. And during menopause, we have a lot of patients at the practice who say, you know, I really can't fall asleep at night. So I tend to read, and while I read, I may have a snack or two. Having a snack or two and they eventually fall asleep and the night brushing is not done. There are some gummies that they may use also containing melatonin to aid in sleep. And unfortunately, they contain sugar, right? And as a result, the sugar stays on the teeth, nice and juicy sugar. The bacteria are just happy to have the sugar, and acids form and the teeth break down into cavities. Mouth breathing also leads to cavities. So if you sleep with the mouth open, sometimes you need to be evaluated for a sleeping disorder. And the dryness in the mouth prevents the saliva from washing away whatever bacteria and food that may be there. And as a result, the bacteria just stays on the tooth and has a field day, leading to cavities. Now, in midlife, there's certain things that are important. And I mean, just generally in life, certain things are important when it comes to teeth. And we want to encourage persons to keep their teeth, because when teeth are missing, your digestion is affected, your speech, your ability to say words that start with T can be affected if you're losing your front teeth. The maintenance of your facial structures. So teeth help to support the surrounding structures and musculature of the face. So the lips, and the cheek muscles get to stay up and have symmetry once the teeth are present. Confidence and aesthetics is a major thing, especially as we're getting mature. We want to make sure we're looking our best self. And if we have no teeth or less teeth than we are to have, then it's affected, especially if a front tooth is missing. So what can I do if I realize that I am missing my teeth? One, depending on how many teeth are missing, I can use orthodontic treatment to close in the spaces, close in the gaps. Two, this is the closest thing to your natural tooth I can replace with a dental implant. So don't fret, many options. If you're missing one tooth, you can use a single implant, which pretty much looks like a screw that is placed into the jawbone. And then a lollipop stick comes out of the screw and a cap or crown is placed on top, replacing the tooth. So when you laugh and smile, not a soul going to know that is not yours. Say you're fully edentulous, you have no teeth in an entire arch, don't worry. You can have an implant supported prosthesis, which is in the middle. So the implants are placed in a row, whether top or bottom, and a denture looking prosthesis goes on top and fits in, so it's pretty firm. If you've lost the teeth on a section, then you can use an implant supported bridge to replace the teeth. If you cannot afford implants, don't worry, you do have the options of dentures. You have the flexi, you have the metal supported, and you have the acrylic. And this gentleman, I think he looks quite handsome after he has restored his mouth. I'm sure he's happy. In this photograph, we have a bridge, and that's another tooth replacement option. The bridge is considered on a case-by-case basis. So with the bridge, you're actually trimming down your natural tooth to aid in support of the missing tooth. So that's why it's case-by-case. But I think they did a great job on this lady here. So as we age, the teeth become yellow. Wearing takes place, not just wearing of the teeth, but also the gums. We have an increased risk of developing gingivitis and periodontitis, which can be caused by changes in hormone level and also systemic diseases. And we have decreased salivary flow, which can arise as a result of medication or chemo agents or radiation treatment. And all of those things result in an increased development of tooth decay and tooth loss. So nothing is better than preventing. What are we to do or tell our patients? Brush twice daily with a soft toothbrush. Floss daily, especially at nighttime. That's when the bacteria has a party. Fortify our teeth. Strengthen the enamel, give it some muscles with some fluoride. Eat healthy, limit sugary drinks, limit frequent snacking, drink water instead of juice, and you'll be good. Maintain your regular checkups. So twice a year rather, for dental examination, routine cleaning, and don't avoid doing necessary treatment because it will cost you along the way. Something that's not mentioned here is smoking. So everything in moderation and little by little, focus on quitting because smoking affects the surrounding structures of the teeth. So that's one thing that we really need to tap into our population to have them reduced because it really is affecting. It also leads to oral cancer. Alcohol use, same thing, troubles you systemically, also leads to issues in the mouth. I would like to thank you all for inviting me and for your attention today. Thank you, Jamaica Midlife Health Society. Thank you so much for the introduction. It was my pleasure. Now throw the questions at me.
Okay, in the interest of time, let's go quickly to the questions in the Q&A. Is non-alcohol-based mouthwash better than alcohol-based mouthwash?
So mouthwash is good to use. The non-alcohol based, what I would say, it stings and burns a lot less. So it's a little bit more comfortable that's to the patient than one with alcohol.
Next question. Is it true that mouthwash can cause oral and throat cancer?
I've never heard that one, so I will go and look at that one.
Yes. Can you tell me more about chlorhexidine, gluconate, and how this helps with gingivitis?
That's an
Magda, one
excellent
quick
question.
thing. Remember we said that there were a couple questions for Dr. Green and we lost, so people can ask them at this time. Now back to you.
That's an excellent question. So chlorhexidine gluconate is actually one of the agents that we use to control gingivitis and periodontitis. It is a simple mouth rinse that the patient would use twice a day for 30 seconds. And we allow them to use it for 2 weeks, and that significantly helps gingival health and periodontitis. It does not work on its own, so it's in conjunction with cleaning or scaling and root planing to improve periodontal health. Yes.
All right, last question. No,
Sure.
second to last, penultimate. It's encouraged that we sometimes chew on less soft foods in order to help strengthen the mouth, the tooth enamel. Considering that problematic bone chewing habit, how do you advise, or what do you advise? And how much of a role does calcium and/or vitamin D deficiency play in tooth decay and fractures generally?
All right, so I'll start with the latter part. So calcium deficiency and vitamin D, that affects the actual jawbone of the tooth. And it's very important to supplement with supplements to aid your jaw in supporting the surrounding tooth structures. That's different from fractures of the tooth. So once the tooth is developed and fully formed, calcium doesn't really help it at that much, but it will help the surrounding structures. The first one, did they mean hard food diets instead of soft
Yes.
food?
Yes, I think that's what it meant. It's no longer in the Q&A anymore. But before you leave, last question, then we're going to go to
Before Magdalena, please, I wanted to ask a question, but I was unable to type it. How will toothpicks, will they affect the gum or the teeth, doctor?
Excellent question. They surely do. So depending on where you put it, it can aid in forming a pocket. So remember that slide that showed the space in between the teeth, the gum and the tooth. Toothpicks, repeated using it, creating habits, create space in between the tooth. Also, some persons, their recession can be caused by sticking the toothpick in the gum. And sometimes the toothpick, the very tip of it gets lodged in the gum and we have to remove it because it then causes severe inflammation. So all of those habits.
All right, last question from one of our
Thank
colleagues.
you.
You're welcome. Last question from one of our colleagues, and I hope I'm saying it correctly. They're asking if at age 65 you should put in a bridge. I think that was the question.
Pardon me?
The question was, I'm not seeing it up in front of me. But
It's brace. It's a brace, not a bridge.
A brace, if somebody who is age 65 and over should use a brace.
Braces, I'm assuming.
Yes.
Braces is for any age once the bone and the gums can support it. I have patients who are 70 something and they're in braces because it's needed. So if you're not able to have proper alignment to give you function, the ability to chew, then the patient is put in braces. But if you have shaking teeth, braces is not recommended. I would say it's a case-by-case basis. Because if you're 70 and your gums and your teeth are healthy, you just want to have that perfect smile, no problem. But if you're 70 and unfortunately, the teeth and surrounding structures are not okay, then as a result, we would not recommend braces. In terms of bad breath and the stomach, so GERD and all those things, reflux, can cause that bad breath. There's a link there. And also, how you get into that GERD. You have less teeth in the mouth, less surface area to chew your food, and as a result, you end up with digestion issues, and then it leads to bad breath.
I must tell you, as the final presenter for today, you got the same commendation as the previous two presenters. Excellent presentation. And on behalf of Jamaica Midlife Health Society, I'd like to thank you. And I now go back to Dr. Lisa for the other questions. Thank you very much.
Thank you for having me. Have a good day.
I know there were a couple questions before.
Fidelity, member of Abbott Nutrition. Today, we will be looking at Glucerna. With diabetes, what, when, and how much you eat can make all the difference. Breakfast is important, and then so are the snacks between the main meals. Glucerna can be one of those small meals or snacks. It is diabetes specific, high quality protein, calorie controlled, convenient, and with specific carbohydrates to help minimize blood sugar levels. Yes, nearly 50% of people with diabetes may be struggling to manage blood sugar. Glucerna is made with Carb Steady to help manage blood sugar. Carb Steady is a blend of carbohydrates that are slowly released into the small intestine and are later released into the bloodstream to help minimize blood sugar spikes. Now the next slides will identify 4 Glucerna products that are readily available in the supermarkets and are mentioned according to the levels of protein from lowest to highest. Our Glucerna Snack Shake. It's a delicious snack replacement. 7 grams of protein, 5 grams of sugar, 140 calories. Now note 26 essential vitamins and minerals. This will be the standard for all of our Glucerna products. Now here's your Glucerna Hunger Smart Shake. Designed to manage blood sugar and hunger, it can be a meal or snack replacement. It contains 15 grams of protein and, depending on the flavor, 4 to 6 grams of fiber. Now that combination will help you manage hunger. It's 1 carbohydrate choice per 10 fluid ounce, and it's clinically shown to minimize blood sugar spikes compared to your high glycemic carbohydrates, supporting the immune system with antioxidants, your vitamin C and E, and selenium. Now remember, I mentioned the importance of breakfast. If there is any doubt that your decisions for breakfast are not helping to keep the blood sugar levels relatively steady, make the smart decision by choosing Glucerna Hunger Smart. This graph just shows plainly that using your usual standard breakfast of regular carbs versus your Glucerna, you will see that the standard breakfast gives you blood glucose response after breakfast compared to that steady green line. It's 50% reduction in positive air. Your Glucerna Hunger Smart powder, 22 grams of protein, 1 gram total sugar. It's a convenient, ready-to-mix snack replacement for people with diabetes. And for your Ensure reminders, your complete, your max protein, and your Ensure plant-based. Why do I have this slide up? It's a reminder that protein is important to maintain strength and energy. Remember that between the ages of 40 and 70, we can lose up to 8% of our lean body mass. Then that loss can jump to as much as 15% every decade after that. Your protein and calories can help reduce muscle and weight loss. And studies show that more than 40% of adults older than 50 may not consume the recommended daily allowance of protein from food alone. So here's your Ensure Complete, 350 calories and 30 grams of protein. Your Ensure Max Protein, 30 grams of protein in 11 fluid ounce, 150 calories. And then, if you don't want dairy, if you don't want soy, we have Ensure Plant-Based for you. It's 20 grams of protein. It's sourced from fava beans and peas. And as I said, 180 calories, 5 grams of fiber. We have you covered for protein. So, thank you. On behalf of Sandra Burt-Green and Paul Russell, I really thank you for your attention. Goodbye.
Okay, thanks for that presentation. And I believe in the interest of time, and thank everybody for their patience. We are wrapping up now. And we're now turning over to any questions you have there, Dr. Lisa? For Dr. Harris, I think it is. No questions?
I'm not seeing any right now. They went previously.
So over to Dr. William Brown and the vote of thanks from Dr. Anna J. Brown Morgan.
Thank you very much. Just to say quickly that we've had a very good meeting this afternoon, a feast of information and knowledge, one of a kind, quite heavy, but very, very good for all of us. Starting with the Professor Morrison, who actually charged the JMHS to go Caribbean. So our next step is to go Caribbean. Very interesting indeed. Our first speakers started with normal eyes, what the normal eyes are supposed to be. She spoke about the Snell chart. She spoke about quantity versus quality of vision, that's the contrast sensitivity, and how it declines with aging. Highlighted on glare, the changes in glare, on our use of LED lights, our computer reduction of blinking because we are looking at our PC screens all the time. Spoke about flashes and floaters, and also with dry eyes, where there was a controversy in terms of why are my eyes running water if they're supposed to be dry. And then I realized that as you age, you can have dry everything. You can have dry eyes, you can have dry skin, and you can have dry mouth as the speakers went along. And the first speaker spoke about abnormal changes in the eyes. She mentioned refractive errors as one of the most important causes of blindness in Jamaica, cataract, glaucoma, diabetic retinopathy, and macular degeneration. And it was quite interesting because he mentioned some things we could do to reduce some of these things, you know, examination of our eyes regularly, and to eat right, to exercise, and to wear glasses, good sleep, and avoid PC screen, especially at night. Our second speaker spoke of normal properties of the skin and compared physiological changes to pathological changes. When we see those things, which will make us go to see the skin specialist. He spoke about factors affecting the skin, which could be intrinsic factors versus extrinsic factors. Some of the intrinsic factors were our genes, our race, extra sweating, photoprotection, and some of the external factors were UV exposure, pollution, diet, etc., including alcohol, because alcohol dehydrates our skin and lessens the availability of vitamins. Sugar, diabetes, that also destroys the sugar in a faster way. And I heard one little thing that I like, black don't crack. That was the first time hearing. Yes, some black crack. Look at your heel. And as you age, you can have all those lesions on the heel. She spoke about types of photo-aging of the skin, the treatment options, and the protection that we can get from all the details. Sunscreen, yes, you can get acne after midlife. And she explained why that was, because of the relative rise of testosterone versus estrogen. She spoke of the choices and options of treating acne. And then we compared female pattern hair loss versus male hair loss, whereby, you know, hormones were playing with. And one thing which struck me was that men who lose hair before 20 years of age are prone to have more prostate issues. That was first for me, I learned. And then she went on and spoke about dryness of the skin, and then eczemas. Then talk about aging spots and aging dark spots, etc., with facial hair or hirsutism. Finally, our final speaker on oral health spoke about the normal mouth and how we can keep it healthy, prevention by brushing, flossing, fortifying with fluoride, healthy diet, again, increasing hydration, cereals, grains, cut down sugar and starch, and cut down soft drinks and smoking. Dental visit twice a year, she says, even if everything is okay. And as we age, our teeth may yellow up due to coffee or caffeine, smoking, gum recession, and gum diseases, and how these cavities are prone to arise as we age. She spoke about gum and gum disease, gingivitis, and periodontitis, and how they are presented, they are manifest, and what can be done to treat them. And then the diabetic with gum disease is also more frequent. Similarly, there was a connection between periodontitis and cardiovascular diseases. Quite interesting. She went on further and explained what is dry mouth and how some of those other diseases could be treated, including root canal treatment, dental implants, dentures, braces, bridges. So you see we have dry here and dry there and dry there, dry mouth, and how we could have bridges. Interesting, over a dry patch. And then smoking and alcohol use. Overall, it has been a very big feast of information for all of us. We are learning, and we're happy that we tackle these topics which come with menopause. Thank you all for coming, and I'm going to leave the rest to the moderators. Thank you.
Shall I go ahead? It is now my opportunity to say thank you. We have at last come to the close of our webinar for the day. And dear colleagues, and all participants here today, when we have been having our third midlife conference and webinar, and the final one for this year, where we focused on the impact of menopause and andropause on your vision and skin and oral health. Not only did we hear more about how age alters our body functions, but we learned more about the JMHS itself, why it exists, our goals, and how we function. I would like to take this opportunity to invite those who are with us here now to join with us. It's inexpensive, beneficial, rewarding, and educational, and will make you a part of a caring, praying, and sharing family of active, older, and not so old individuals. Contact us, please. And now it falls to me to say thank you to the participants of this webinar. I would like to thank our excellent moderators, Mrs. Magdalena Cooper de Nuez, and who is our Assistant PR Officer, and Dr. Lisa Kervin-Dawes, who both were very, very competent and efficient as they took us through the day's events. Dr. Kervin-Dawes, our Vice President, also effectively delivered the opening remarks for the conference, while Magdalena opened our day with prayer. We also thank Dr. William Brown, our dear President, for welcoming us all and for bringing greetings as well as closing remarks. Many thanks to Professor the Honorable Errol Morrison for opening the conference today, and to the Honorable Marigold Harding, who also brought greetings. speakers today were Dr. Angela Mattis Johnson, an ophthalmologist, Dr. Llorenia Muir-Green, a dermatologist, and Dr. Sarah Tibby, a dental surgeon. Their talks were interesting and brought us a new perspective and appreciation of those areas of our body, which we often take so much for granted. We just all need to take better care of ourselves and these bodies that Father God has gifted us with. Significantly, we have without a doubt to thank our esteemed sponsors, without whose support it would have been much, much more difficult to hold today's conference. Our thanks to Alcon, which is a part of CariMed Group Limited, to Health 2000 Canada Incorporated, Medimpex Jamaica Limited, Indus Life Sciences, the National Health Fund, the Jamaica Observer Limited, and Abbott Nutrition. We are grateful for their support and look forward to their continued support of this very special organization, which speaks particularly to the health of the middle-aged and elderly people in Jamaica and across the Caribbean. Stay with us, please, sponsors, and continue to support this worthy organization. Our thanks go to Sam, Mr. Samuel Heron, our capable information technologist. He has guided us with competence and with a great deal of confidence through our webinars this year and for several years. He is indeed reactive and proactive to our needs. Thank you, Sam. I cannot close without mention of the JMHS team, which has worked assiduously over several months to make this occasion possible. I thank you all. I in particular would like to thank our secretary, Miss Marcy Tuller, who has been the cement responding to all registered participants and their needs and the organizational needs also. We thank you, Marcy. It is now time for me to thank you, our participants in today's webinar. I hope you found your time well spent with us today. And I invite you to join with us as we continue our series of educational webinars in 2024. Best wishes for your coming week. And I'd just like to say best wishes all. Thank you very much for coming on board with us today.
Thank you so much.
Thank you all. Thank you. Thank you.
Thank
Thank
you
you.
so much. Dr. Lisa, we also had a great time, so we'd like to thank everybody for coming on. Have a great evening, as was said before, and a great week, everybody.
Thanks again to everyone.
Thank you. Thank you. Have a safe weekend, everyone. Bye-bye.
And you too.
Okay, chat.